If you do routine rhinoplasties, your Queensland, you do? Brilliant. Okay. Okay. And you? Ah, that's perfect. And you? Okay. Okay. In which medical college? Oh, that's great. Yeah. Right. Okay. Ham production. Okay. Yeah. We have the all different type of the deformities, and I just try to put the cases on the day one. We have the little bit the simple case, and then two, and then I graded manner. So that's good for you, and that's why I keep first the cadaver. So we just learn the 3D anatomy because we have the limitations in cases. But in cadaver, we can so it's very difficult to arrange the cadaver, but it's good for you. You are lucky that we have the cadaver. So we, yeah, the yesterday the postmortem of the body. I do did a lot of people have like the press cadaver because they have the lot of body donation program on there. We have all lectures or some things that we have all cover all these things. Vijay, yeah, this entire thing is recorded, the full HD recorded. So that I'll provide you. And we have other short videos of the different techniques and like one crooked nose and one like the binder syndrome, how you augment. So we have unedited video the where you do the mistake. So that I'll provide. क्या हुआ? हाँ मैं तो रेडी हूँ आप मेरे को बताओ. First हाँ. Oh, we waiting for you. What? So no, don't worry for that. Don't worry for that. Uh, yeah, don't scare. The first day, don't scare for the exam. So you reached there yesterday night? No, today morning. Okay, okay. लाइव करें क्या? अभी लाइव नहीं. अच्छा ठीक. So earlier you met with the Dr. Sandeep in that room. So he also asking about you. So you met them. The most difficult aspect of is my course, just to collect the patient, just to collect the patient, because we need around the 25 patients. So sometimes one of the patient have some problems, some unnecessary situations at the time of the before surgery reviews, some family problem, some pre-anesthetic checkup problems. So the most difficult I say is just collect the patient. My passion basically on the rhinoplasty and the rest of surgery, like the ER, interlate tympanoplasty, I do. But my other colleagues, you finish all these things. And I am particularly love the rhinoplasty. Yeah, yeah. Interlay different type of the ossiculoplasties, intact canal, all these things. पूछ के आना क्या हुआ? लाइव करें क्या? नहीं वहां पे देखो लाइव जा रहा है, उनको पूछो वहां पे. Whenever you start the case now and you develop your habit, the systematic manner, all of the pre-operative workups, operative steps, pre-operative photograph, post-operative photograph, and then you just try to critique. Then what is your lacuna in my surgery, my result? Then you learn the things. हाँ वो फेसबुक पे नहीं जा रहा क्यों वो उधर कर रहे हैं जस्ट कम क्या प्रॉब्लम हो गई उसमें ये क्या वर्चुअली किया था अपन ने उस चक्कर में है क्या तो दोनों में से एक में भी नहीं आ रहा हम्म हम्म। कोई बात नहीं माय वॉइस माय वॉइस इज कमिंग ऑन यूट्यूब चेक देख माय वॉइस इज कमिंग ऑन यूट्यूब है ना इसकी वॉइस वॉइस बंद करना मेरी वो करना. Okay. Hello. So now we start. Earlier, I think we have some technical issue. So first of all, I welcome all of you in this seventh my global Rhinoplasty Fellowship program and in this cadaver dissection program. And I welcome to all of my participants. They come from the far away, from the across the world, from the Malaysia, Saudi, and from the Saint Kitts and different part of the India for joining this course. Today we basically learn the all basic steps and the advanced step of the rhinoplasty. But really, before to start the cadaver dissection, we just little bit discuss in the brief. Still, I realized that there are so few people that they want to pursue their career in the rhinoplasty. So I realized that why the few people they want to pursue the career in the rhinoplasty, because really the rhinoplasty is the most difficult surgery in the rest of the all of the facial plastic surgery. So there are some challenging factors that make the rhinoplasty surgery is a complicated and complex surgery. The factor first, the nose have a great anatomical variation that make it complicated. So you have to know the comprehensive knowledge of the normal anatomies, then you judge about the abnormal anatomy, about your deformity, and you know about the normal aesthetic parameters of the nose. You know about the dynamics the dynamics that maintain this normal anatomical relationship. And the second challenging factor, that is that this surgery need the form and function of the nose. So basically is a balance between the cosmetic and functional aspect of the nose. Suppose you give a very beautiful nose to the patient, but your functional aspect is not good, then it's very difficult to satisfy the patient. So basically you always remember it's a balance between the cosmetic and functional. The third important challenging factor, that the result of this surgery match with the expectation of other mind. So these three factors make really the rhinoplasty is the most complicated surgery in the rest of the whole facial plastic surgery. So ideally there is no standard rhinoplasty. Your incision, your approach, and your techniques, that according to the specific anatomical deformity and your patient desire. There is no specific, there lot of techniques in same patient you use. So basically you have a set pattern to learn the rhinoplasty in your mind. You have some basic steps in your mind, like whenever you do the rhinoplasty in a patient, then you have some five basic steps you follow for learn the rhinoplasty. The step first, uh, the patient concern. You always ask to your patient, either your patient concern is regarding the appearance or regarding the breathing. Either he want only the cosmetic or the functional. And the second part of this patient concern, we always read that the patient is psychic or something, the patient is not good, but you always know your comfort zone of the surgeon also. Whenever you do in the beginning phase, then you do the cases according to your comfort zone, because once you do a good surgery in the beginning days, then if your patient is happy, then really your confidence is built up. But in the beginning career, if your patient is not good, that is not in your comfort zone, and the result was not good, it creates the nuisance, and then it develops so problem. So this is the first step, and the second step, that is the patient analysis. Your patient analysis, that should be perfect. You have the proper history. After the COVID, the lot of the patient have a anosmia problem. So if the patient have such, like, your history should be proper. If a patient have a anosmia, then you document it. Otherwise, you blame after the surgery. So the history, the physical examination, In physical examination, the skin examination, soft tissue envelope is important, because if sometimes a patient have a scar on the skin and later he blame to you, so you all things are documented. And the endoscopic examination, uh, I realize that some patient have the nose is good, but they don't have the good functional. So especially happened with this my plastic colleague friends, because they routine don't have the endoscope in the OPD. You complete examination by the endoscope, because when you not examine by the endoscope, then you miss the infinite condition. Sometime your patient have a posterior septal deflection, so you always do the endoscopic examination. So this is the second learning step. And then the third, your approach and operative step. Before to your case, you worksheet, you complete your all operative step in the systemic manner. And then the four, your outlook analysis. Then you compare your pre-operative photograph with the post-operative photograph. And then the last step is the critics. You do your own critics. Where is my lacuna? Definitely, sometime a patient have a gross deviation and a crooked nose, and the patient is happy after the surgery, but you are not happy. This is the critics. So you improvement that critics. How you improve? Then you have a mentor, you have a teacher, just like a Pon and the other renowned surgeon. You follow that, and then you read the one standard book, not so many books. First you read a one standard book, and then other book, then go for the YouTube videos, go for the hands-on cadaveric dissections, and then hands-on on the live patients. And the things you always remember, the comfort zone. When you do, if the patient is not in your comfort zone, not try to do. And one another important thing, you always patience. क्योंकि in rhinoplasty you need the patience, because it's the surgery of the patients. So this is a basic set pattern to learning the rhinoplasty. So in this basically today in cadaver dissections, we learn about the all steps. So for just try to making the simplification the anatomy, we divide this bony pyramid in the three part: the upper one third part, mid one third part, and the lower one third part. Okay, so the upper one third part, basically this upper one third part bony vault, that consists by a pair of the nasal bone and a frontal process of the maxilla and rest of five important attachment. And the mid vault, that consists by the upper lateral cartilage, a pair of upper lateral cartilage. And the lower vault, this lower vault consists by a pair of the alar cartilage or lower lateral cartilage. And from the top to bottom, we have the bony septum, we have the cartilaginous septum, we have the membranous septum. So this entire inner framework of the nose, that cover by a outer soft tissue envelope. So this outer soft tissue envelope have some important surgical landmark, important their own blood supply. So first we learn about the important surgical landmark of the nose, then we discuss about the blood supply, and then in systemic manner we one by one we discuss all these things. So in important surgical landmark, first if we discuss about the bony vault, regarding the bony vault, we have some important surgical landmark. One is glabella. So what is glabella? Glabella is the most prominent part on the midline of forehead. This is the midline of the forehead. So the most prominent part in the midline of forehead, that is the glabella. Why we know the glabella? Why, basically what is the clinical significance of the glabella? Because this glabella, below this glabella we have a important muscles, the procerus muscles, that is responsible for in the bunny lines or the horizontal radiates on the skin. So sometimes these procedural muscles during the excessive dissections, this damage and cut it, and then upward contract, and the patient have a gradation profile. And on this point, we also measure when we examine the face na, from the trichion to the glabella we have the upper face, and from the glabella to the basically this subnasal we have the mid face. So it's a important, basically we measure also aesthetic angle also from the glabella to the nasion. We measure this nasofrontal angle. So this is the glabella. Now the next important landmark, that is the radix. What is the radix? Radix is the root of the nose. Radix is the distance of the frontonasal suture. And the deepest point on this radix, that is the nasion. So in profile view, we can appreciate this deepest point, this profile view, that is the nasion. So basically the nasion is the upper limit, and ideally in a female patient usually fall this the supratarsal fold. Okay, so this is the upper limit of the basically the paramedian or osteotomy, because above this we have the thick part of the nasal bone. And then if you come down, then we have the rhinion. Okay, so what is the rhinion? Basically rhinion is the osteocartilaginous junction, but the soft part on the osteocartilaginous junction we call the rhinion. The soft part of this osteocartilaginous junction, that is the rhinion. And below the bony part of this osteocartilaginous junction, that we call the salion. On this rhinion, the two things are important. First, look, if you compare this soft tissue envelope thickness, na, the soft tissue thickness is the greatest in this nasofrontal suture area, but in this rhinion mid part, we have the thinnest skin. So, great care should be taken during the lift up the soft tissue envelope, or sometimes, when you rest the hump, then later the patient have some irregularities in the rhinion, because we have the thin skin in this area, thinnest skin in this area. So you properly smoothing below this area. Another, we have a very important area below this. What is that? What is the name of that area? K area, keystone area. So what is the keystone area? The keystone area is the confluence of the four structure. Two, that is the bony, and two is the cartilaginous. In the bony, we have the nasal bone and the bony septum, and in the cartilaginous, the upper lateral cartilage and the cartilaginous septum. Whenever we open, then we see that in this K area, basically the upper lateral, basically nasal bone and the upper lateral have a specific configuration like this. That means the distal part of this nasal bone and proximal parts of the upper lateral cartilage, they overlap like this. So the overlapping, that is maximum in this keystone area, central part. So in the central keystone area, this overlapping is maximum. So this upper lateral cartilage get maximum support from this area. But if you go on the laterally, in the peripheral area, the overlapping is reduced, around the 9 to 10 millimeter overlapping in the central part. But if you go on the laterally, that is overlapping is reduced. So you always remember, then you always try to maintain integrity of this area during rhinoplasty. Particularly, if a patient have a crooked nose or deviated nose, in that case, he have a most and more chance of the injury or disruption of the keystone area. There are so many other methods, and then we discuss later. Then, if the keystone area is damaged, then how we reconstruct it. So, these are the glabella, the radix, the nasion, the rhinion, salion, and the keystone area. They four or five the important surgical landmark regarding the bony vault, the upper one third. Okay. Now, if you come down in the mid part, Dr. On always said it's very important cartilage, because this cartilage is a bridge between the upper one third and the lower third. So it's a subserving cartilage. So this cartilage medially, laterally, superiorly, inferiorly say very important four surgical areas, surgical landmarks. Medially, the medial end of this upper lateral cartilage that attach with the septum. The attachment of this upper lateral cartilage with septum that have a specific configuration around the 10 to 15 degree that we call the internal nasal wall. That we call the internal nasal wall. So whenever do the rhinoplasty, we always maintain the integrity of this intranasal wall where area by the spreader graft, by the spreader flap, by the flowering sutures according to the patient need. Okay, and the lateral most part of this upper lateral cartilage, this upper lateral cartilage is just triangular shape, and the lateral end of this upper lateral cartilage that have the doesn't sound attachment is just only a wedge of triangle or bone just lateral to the anterior end of the inferior turbinate. The lateral end of the upper lateral cartilage is attached. What's the name of that area? That's the Webster triangle. So this Webster triangle, the attachment of this, sometimes what happened when you do the osteotomy, then if this Webster triangle area is damaged, then what happened? Yeah, when this inferior, basically Webster triangle area is damaged, then the lateral end of the upper lateral cartilage is medialized, and because in the same place, the anterior end of the inferior turbinate is also attached, so that is also medialized. Consequently, later the patient develop the breathing problem. So just to prevent this damage of the Webster triangle area, when we discuss about the osteotomy part, then how can we prevent? Okay, so this lateral end is also a important this surgical landmark. We already discussed the superiorly we have the keystone area, and inferiorly also we have a important area that we call the scroll area. When we open the nose, then we see that basically this lower part of the upper lateral cartilage and upper part of this lateral crust part of the LR cartilage, they have a configuration like overlapping this one. So that we call the scroll area. That we call the scroll area. Why the scroll area is important? Why the scroll area is important? Because you know, uh, we have this anatomy, and behind the anatomy we have some aesthetic relationship, and this relationship maintained by some dynamics in the nose. Nose have their major tip support and some minor tip support, you know. So the nose have three major tip support. First, that is the entire size, shape and resilience of this entire LR cartilage. And the second tip support, that is the scroll area. That is the scroll area. And the third, the attachment of this caudal part of the septum with the medial crust. So the three tip support we always maintain because they maintain the normal relationship of the aesthetic parameter. When we go for our lecture, then we have the Anderson principle or for something. So related with this upper lateral cartilage, we have the four area. One is the internal nasal wall area, that is on laterally we have the Webster triangle area, superiorly we have the keystone area, and the inferiorly we have the scroll area. Okay, now after the mid one third we come on the lower one third. Okay, for the lower one third, for a normal man, for a normal ENT surgeon, this entire is the tip. But for a rhinoplasty surgeon, this entirely is no tip. We know is the different part of this important surgical landmarks regarding. So this anteriorly most projected part, that is the tip lobule. Okay. And on this anteriorly projected part, there is two light reflecting areas that we call the, what's the name of that one? Tip defining point. Perfect. That is the tip defining point. So they are the lateral boundary of the tip. Okay. And if you go the superiorly, then where the tip end and where the dorsum start, that what's the name of that one? Supratip brake. That is the supratip brake. Why we get the supratip brake? Why we have the supratip brake? Look that ideally for a normal aesthetic pleasing appearance, particularly in a female patient, uh, the tip lead this dorsum, okay, and there is a specific relationship between the anterior most part of the caudal septum, anterior septal angle between the dorsal part and the caudal part of the septum, and the dome part of the intermediate crust. They have a certain a relationship that responsible for the shape of the tip. If this is the when we open the nose, we see if this is the basically anterior septal angle and this is your dome. So the dome that is 1 centimeter anterior and 0.5 centimeter caudal. That means this dome that is the 1 centimeter anterior and 0.5 centimeter caudal. So due to this distance, we getting the supratip brake. Okay, and where the tip basically end and the columella start, that we call the infratip brake. That we call the infratip brake. So this is the supratip part, this is the infratip lobule, and these are the tip defining points. So this is the basically important landmark regarding the tip. And if you come down below this vertical column like structure, that is the columella. Uh, Basically this columella part, this is responsible for the projection of the tip, and this columella basically have the two part. These are the foot plate of the columella and these are the pillar of the columella. Okay, and if you go on the laterally, then this lateral free fibrofatty tissues, this lateral free fibrofatty tissues, that we call the ala lobule. So ala lobule have the two part, two important surgical landmark. Ala were attached with this cheek. What is the name of this? Ala facial junction. And the free margin of this ala, that we call the ala margin. That is the alar margin. The important thing regarding the ala doesn't have any cartilage. This is important, you concept in your mind. Ala doesn't have the cartilage. When we open the nose, then we see the configuration and orientation of the lateral crust. Uh, this is especially for my junior colleagues because the lateral crust have the orientation just like towards the lateral canthus. Towards the lateral canthus. Look that. And this completely only the small anterior part that have the support through the lateral crust part, rest this is the completely free. So ala is only the free fibrofatty tissues, doesn't have any cartilage support. And this is the third part of this lower part of this tip, and the fourth part, that is the part medial to this ala and lateral to this columella, this is the nostril. This is the nostril. So the nostril, they have the two important surgical landmark. One, at apex of this nostril, what is the name of this? Soft triangle area. We have this soft triangle area. When we open the nose, then we see then why we have this soft triangle area and what is the clinical significance. Because in soft triangle area, you know, the dome part of place doesn't have sound cartilage, they have a notch. So due to the notch, very dense skin to skin approximation in this soft triangle area, don't have any subcutaneous tissues more. So this part is more prone for the injury during the marginal dissections, and if you have the injury, then it creates the notching. So it's also important. This is the clinical significance of this soft triangle area. And if you come down this posteriorly cylindrical area, what's the name of that? Sill of the nose. So this is the sill of the nose. So the sill of the nose that decide the width of this nostril. So these are the important surgical landmark then you have to know in your subconscious mind when you examine the nose. And now all these subunits and the part of the nose, they have some certain aesthetic relationship that you have to know uh, for the rhinoplasty surgery. Like first, the width. You know, the width of this ala base, the inter-alar bed width, the distance between the alofacial junction, that is ideally equal to intercanthal. This medial canthus and this medial canthus, if you this intercanthal distance, that is equal to this ala base width, and this width of this bony dorsum. When we open the nose, they see that these have the two type of width. One is the bony base width and one is the dorsum width. But the width of this part, that is around the 80% of this ala base width. If more than 80%, then you think about the osteotomy for the narrowing of this bony dorsum. And another relationship between this ala margin and this columella part, ala and the columella relationship. So this columella part that should hang little bit down to this ala margin. That is a appearance that we call the columella show. That is around the 2 to 4 millimeter. And just like a gull wing appearance or gull in flight appearance. So this ala have like the relationship with this columella. And this tip, ideally the distance between the tip defining point also, that is the 6 to 8 millimeter in a female patient and 8 to 10 millimeter in a male patient. And if we then learn the another thing, then if you met the whole point na, this supra tip break and the tip defining point and this infra tip break, then this is a isosceles triangle, equilateral triangle. That means this upper part, supra tip part and the infra tip part, that basically should equal. That should equal. It's the tip diamond. It's the tip diamond that should equal. If that infra tip and this part is prominent, that means there is some deformity and problem in intermediate crust. So we manage when we discuss about the tip, then by the tongue in groove and then different techniques. So we discuss. But you first you know the normal anatomy, then you judge the abnormal anatomy. If you don't know the what is the normal interalar width and what is the relation, then how you judge you need your that osteotomy or not? So this is the importance of basically anatomical knowledge. If you have like the more than this distance, if you have more than ala base width, then you exercise this ala base. But if you more than this width of the nostril, then you exercise the seal area. So how you judge? Once you know what is the import, which is the seal, which is the ala base. So these are the important all surgical landmarks regarding this bony vault. So, so now after this bony vault, this soft tissue envelope that cover this entire nose framework have uh, the compositions and the blood supply is also important. If we discuss about the composition, then we made up by consist by the skin and the subcutaneous tissue. Skin have the epidermis and dermis, and the subcutaneous tissue have the four important layer. One is the superficial fatty layer, and then smash, and then deep fatty layer, and then perichondrium or periosteum. So the superficial fatty layer, they have some like the horizontal and the vertical septage. So they transmit the force of the smash layer. What is the smash? Smash is basically the continuation of the gallia aponeurosis in the face, submuscular aponeurotic system. So above the smash, all vascular and the nerve supplies. So smash layer basically is an important layer that transmit the basically the contraction and the force of to the skin. And when we go the dissection, then we always go to the subsmash. That is the complete avascular area. Okay, and the thickness of the skin is also important, and it's a very good, because in Indian patient, and like the in Gulf patient, we have a very thick skin patient. And when you have a thick skin and the thinnest patient, then you always explain to the patient about the result, because when you have thick skin patient, you have certain advantage and the certain the disadvantage. What advantage when you have a thick skin patient? Because when you put the graft, then graft material are better tolerated, and that not visible post operatively. But on the other hand, you have the disadvantage, because you need a lot of work to change the appearance of the nose. And sometimes when you do the lot of material, you add on things, then sometimes the nose is bigger. So you, this thing you always keep in your mind. You never try to cut more and more, because when a patient have thick skin and patient need the good refinement in the nose, when sometimes my beginner friends, they do the lot of excision in the nose, like the cephalic trimming, and then ultimately what happened? The nose is collapse. Patient develop the LR retraction. So you always maintain these things. You never, patient need a good nose, normal size nose, never the retraction or never the oversized nose. And on the other hand, when you have the thin skin patient, definitely you have the advantage. Your good refinement are in the early stage, but sometimes the graft material is visible. So when you use the graft in a thin skin patient, then you bevel that margin edge of the graft. You cover where you rest by a temporal fascia or something. So this is the importance. Basically, you ask to your patient, then it will take time to the 18 months or 2 years just to getting the complete results. This is the importance of the skin, soft tissue envelope. And one important aspect, the blood supply of the nose is also, because uh, sometimes when we do a lot of complications. So if we discuss of the blood supply of this entire nose, we getting from the two system, one from the ophthalmic artery system and another is facial artery system. Perfect. So from the ophthalmic artery system, we have a terminal branch of the ophthalmic artery just at the mid part, that emerge from the mid part, that we call the, what is the name of that? Dorsal nasal artery. So that dorsal nasal artery is the terminal branch of this ophthalmic artery that comes in the medial end and then run anteriorly on the dorsum and the come down. And it's a example of the external carotid and internal carotid artery, the communication, anastomosis. Okay. And another supply from the facial artery at the angle of the mouth. At the angle of the mouth, here the facial artery divide in the two branch. One is the superior labial artery, one is the superior labial artery. This superior labial artery, इसको थोड़ा सा इस पे नीचे कर देना ना यार, विजय कहाँ गया? One is the superior labial artery that run on the lower part of the upper lip, and another is the angular artery, that is another is the angular artery. So basically this facial artery have the two branches, कोई बात नहीं, इसको यहाँ fix है. One is the superior labial artery and another is the angular artery. At this alofacial junction, at this alofacial junction, this angular artery gives some branches, that is the lateral nasal arteries. So this lateral nasal artery and this superior labial artery that gives some branches, this to columella, that we call the columellar arteries. Now what happened? Some branches of this dorsal nasal artery, ठीक है, ठीक है, आप इसको यहाँ फोकस कर दो, आप छेड़ो मत इसको बार बार. Some branches of this dorsal nasal artery and some branches of this lateral nasal artery have the anastomosis, that we call the subdermal plexus, just above the smash layer. Okay, and some branches of the lateral nasal artery and some branches of the columellar vessels along the lower margin of the lateral crust, they have the anastomosis that we call the LR arcades. So We learned that this is the vascular supply of the nose, but what is the importance? Why we know the importance of this knowledge of the blood supply, especially during the filler injection? What happened, when we inject the filler, particularly in radic and nasofrontal suture area, sometimes the patient develop a the disaster. The filler ultimately goes through the dorsal nasal lateral artery, through the anterior and posterior ethmoidal artery. The filler ultimately goes in the central artery of the retina, and that is the end artery. Ultimately, the vision is lost, and you never think about this disaster. So, whenever you inject the filler, then you have to know where you working, what is your depth of infiltration. You know complete about the vascular anatomy, and you have to know the disaster management. If something, Dr. Pon, they just tell that how we manage that things, because so there is the importance. Another importance, like when we make the transcolumellar incision, when then we inside this basically a columellar branch of the superior labial artery. So almost now the entire blood supply of the tip is dependent on the lateral nasal artery. So during the ala base excision, you never go more than 2 mm outside of this one. So you can prevent the injury of the lateral nasal arteries. This is the second significance of this vascular knowledge, vascular blood supply of the nose. And the third, whenever we have a thick skin patient, then for getting the good refinement, we evert this and we just defattening of the subcutaneous tissues. If you do the excessively, then you damage your subdermal plexus. Then ultimately the skin of the tip is necrosed. So you always think these things in your mind. This is not routine thing, but you all these things you keep in your mind when you do the case. So this is the importance regarding the uh, blood supply of the nose. So we discussed before to start the dissection all about the soft tissue envelope, importance of the thickness, important surgical landmarks, and vascular supplies, and the importance of the vascular supplies. Now we start our cadaver dissection. Next, open the nose. But before to that, one another important step for a good atraumatic dissection. What is that? That is the infiltration, local infiltration. Look that if you go the systematically in the rhinoplasty, na, if you divide it, I just divide in the 7G steps just for simplification of the learning. In 7G step, the first three and the last, that is the same, like the infiltration, like the opening of the nose, and like the septal modification and closing and the split. That is almost the same. But the three different steps, your bony vault modifications, your mid vault modification, your tip modification, they have according to the specific anatomical deformities. So you just try to learn in the systematic manner. Though we discussed the first G step. G step, that means the golden step of the rhinoplasty, just for basic learning. So for learning infiltration, मेरे को local देना. For infiltration, the infiltration part, we can divide in the 5 steps. The first step, we infiltrate. Uh, Dr. Pon, sir,
Yeah, hi.
you want to add something more regarding the important surgical landmark, or
No, I think you've done a great job. I think just carry on. It's very good. I think let's start opening the nose now, and then
yeah,
we can see
after,
things.
yes, sir, just after the infiltration, we just open the nose.
Yeah.
So basically, the first part of the infiltration, first in the septum. So when you infiltrate in the septum, then you infiltrate, you know where you infiltrate, the site of the infiltration you learn. Then how you decide where you exact infiltrate? It's depend on your deformity, depend on your incision. If your patient have a caudal septum deviation, then you use the hemitransfixation incision. And if your patient have a posterior septal deflection, then you use the Killian's incision. So according to the site of the incision you use, but the important thing, when you infiltrate, then look that rather than basically blanching, you have the ballooning. It help in hydrodissection of your mucoperichondrium. So you infiltrate. Suppose if your caudal part of the septum, then you exact infiltrate on your caudal part of the septum. So it's depend on your deformity, then which type you use. Some renowned surgeon, they use only along the site of incision. They never infiltrate on the posterior part of the septum. But I recommend to my junior colleagues, then you infiltrate anteriorly and the posterior also. So just for getting the good plane. Now the second part of the infiltration, that for the transcolumella
So Neil, the
incision.
reason why you don't need to really inject posteriorly unless it's a revision is once you're in the correct plane in the caudal area,
Yeah,
there's no need to, because you're in a bloodless plane.
yeah,
So this is why I think the only thing you have to be careful with injection of septum is
yep,
you can get tachycardia, and I've had one patient
yeah,
in my career who ended up with a ventricular tachycardia. So it can be quite serious. So be careful when you're injecting the septum. And I think the rest of the nose, it doesn't matter. The skin, it doesn't matter. But the septum is quite vascular, and if you end up with an intravascular injection, it can be quite scary. So this is why I tend to limit the injection purely to the caudal border, because once you're in the correct plane, and I'm sure you will show them how to get into the correct plane, then it's a bloodless dissection. So you don't need. So the only advantage in injecting posteriorly is if you've got a big spur, and that's more for hydrodissection of the spur rather than anything else. But then you can inject saline rather
yeah.
than injecting adrenaline. So my advice is, I hear what you're saying, to young guys, but actually, once you're in the correct plane, there's no need to, and just be careful because it's not without risk injecting into the septum.
Yes, sir. Really, thank you for its nice suggestions. Then, rather than you use local in the posterior part, we can infiltrate the saline just for deglowing your mucoperichondrium. Okay. And then the second part of the infiltration, that we infiltrate for the transcolumella incision from this tip defining point to the anterior nasal spine, like in this manner. And then between the tip defining point like this, and you never infiltrate too much. And in this vestibular skin also, and like the Dr. Pond always told that before to make your I think when you infiltrate, then first you mark your incision. So that is a good habit. So this is the second step, and after the infiltration by your index finger and thumb, like you massage it for the disperse this local. But if you infiltrate too much, then it hide your contour deformities. And now the third step of the infiltration for the along the marginal incision. I usually use the 2% xylocaine in 1:1 lakh ratio, and I usually use this 5 ml syringe and this 26 gauge 1.5-inch needle for the infiltration. You can use the dental syringe or 3 ml also, but this is the good balance and the good support. If you use like the 10 ml syringe, that is not good. So I recommend either the 3 ml or the dental syringe and 5 ml, and this long needle. And already mixed the adrenaline in the 2% while 30 ml that I usually use. So where exact you infiltrate this in the third step along the site of this lateral crust. So how you identify, this is a important thing. This is a important thing. Then how you identify exact where you infiltrate, because this is the same site where you make a incision for the marginal incision. So look that you use always this instrument. This is a good instrument, wide double prong medicone retractor. So you invert the margin by your index finger like this, and in this way, if you feel by a handle of the knife a rigid area, this is the margin of the lateral crust. You can also feel by a cap of a syringe also. So You just along the margin of this lateral crust, you infiltrate like this in the multiple manner. Some of my rhinoplasty friend, they use the cold saline also after the infiltration, just for getting the good hemostasis. So on both sides, I infiltrate really local in this patient because it's a fresh cadaver, so it help in the getting the plane also. So this is the third step of the infiltration. Now the fourth step of the infiltration for the dorsal infiltration. So the again the important thing, Selendina. Again the important thing, what is the exact site of the infiltration? So the site, the junction between the upper lateral and the septum. This is the upper lateral cartilage, and this is the upper lateral, and this is the lower lateral. So between the upper lateral and look that in monitor, this is the upper lateral, this is the lower lateral. So the junction between the upper lateral and the dorsum. But again, the important thing, Dr. Pond, they always teach this thing that whenever you infiltrate on either side of the midline, never on exact the midline. And then when you infiltrate, then you lift up this skin. So accidentally, your needle is not comes out through, because when you inject exact on the midline, now then it hide your contour irregularities. So in this way, and then this is my upper lateral, this is my, can you appreciate this one? This is upper lateral and this is the lower lateral. So again, you pass this one, lift up the skin, you can appreciate this needle. This is my needle. You can appreciate this one? Yes. So this is the fourth step of the infiltration. Now the fifth step of the infiltration for the osteotomy along the lateral nasal wall. Again, where we infiltrate the site, so you identify the inferior turbinate. Uh, because for a ENT guys, the inferior turbinate, they routine handle the inferior turbinate, but for a plastic surgeon, you identify the, because they not usually do. So this is the head of the inferior turbinate. This is the head of the inferior turbinate. Can you appreciate? This is the head of the inferior turbinate. So my dear friends, just lateral to this anterior end of the inferior turbinate, you pass your needle, and then you appreciate this is my needle, this is my needle, but never go above the intercanthal line. And in this way we infiltrate like on the both side. Okay, and you can skip this step because we do the osteotomy later. So at the time of the osteotomy we again infiltrate, but this is the set pattern of the infiltration. So first for the septum, and the second for the transcolumella incision, third for the marginal incision, and fourth for the dorsum dissection, and fifth for the lateral nasal wall for the osteotomy. So daily we repeat all these things. In this course, the most important thing, that is the repetition. When you repeat more and more more and more all these things, then you learn. Now this is the first G step of rhinoplasty, in open rhinoplasty. Now for open rhinoplasty we use two type of the incision. What the incision? One is transcolumella incision and another is the marginal incision, or you can say that marginal incision we connect by the transcolumella incision. Vijay वो gate बंद कर देना. So you know, I go in the different courses, cadaver dissection programs. There are, I realize there are three important questions they my beginner friends ask. Sir, which type of the incision I use first? Either I put the transcolumella incision or the marginal. Some surgeon advocate the marginal incision, some surgeon advocate the transcolumella incision. Second questions they have, which type of the incision is good? Some advocate the stair step is good, some advocate the inverted V incision. And the third common question, sir, what is the exact site of the incision? How we judge? So first you clear these three things from your mind. So the question first, then which basically type incision we use first. So friends, either you use the transcolumella or the marginal incision, it's hardly matter. You forget about that. I usually use the transcolumella incision. Why? The reason behind that, because once I start to open the nose, then my rest of the incision under my vision. That's why I use first transcolumella incision and then the marginal incision. The second important thing, then which type of the incision is good? There are different type of the incision. Inverted V incision, like the stair step incision, like the V incision, W incision. Uh, but always we use the incision in the broken line manner. Why? Because when we use the incision in the broken line manner, then we have a less chance of the scar contracture, less healing forces. So we use the incision in the broken line manner, and the commonly used incision are the inverted V incision and the stair step incision. I usually use the stair and this inverted V incision. Why? Because in stair step incision, marker dena. In stair step incision, because the upper limb of the stair step incision, we use if like this one, the upper limb of this stair step incision that is near this soft triangle area. Sometimes the patient have a asymmetrical broken scar and not good alignment of through the stair step incision. But again, it's a matter of experience. Some surgeons still they use, they have a lot of experience about that. But for my beginner friends, I usually advocate the inverted V incision. So the question second is cleared. Now the third, what is the exact site of the incision? So this is really the most important in three questions. What is the exact site of the incision? So we usually put the incision in the narrowest part of the columella. But how you decide the narrowest and mid part of the columella? So my beginner friends sometimes they make like they point this one and they midpoint. This is the wrong method. This is the wrong methods. Uh, the apex of the nostril. This is the upper part of the columella. So from this to this, you mark the mid part of the columella. This is the narrowest part of the columella. But again, the question why you use on the mid part? We use in the mid part because the skin of the mid part is more approximated with margin of the medial crust. So later during the healing time, you have the less chance of the scar contracture. This is the reason. And another important we earlier discussed that we have below this, we have a one of a important tip support, major tip support mechanism. The attachment of the caudal septum with the medial crust. So we prevent the injury of that one. But sometimes like this, if you want to the deproject the nose, then your incision that little bit higher, because after the deprojection they automatically come down. Or sometimes if we have a flat nose, in India we have a lot of bender's case. You know the Bender syndrome basically is a nasomaxillary hypoplasia, the premaxilla part of the patient that is deficient of the antenasal spine. So this columella part is so small columella, just like this. So in that case, we want to lengthening of your columella, because after a lot of projection, lot of augmentation, we frustrated how we close this. So we need for the lengthening of the columella, we use the incision just like in V2Y manner closing. So we use this axis part of the skin, we use for lengthening of this columella. So in rhinoplasty, you cannot, there is no, just like we earlier discussed, there is no single technique by you complete the case. So according to the anatomical deformity and the patient desire, we change our According to your experience, when you do more and more cases, you change your techniques, you develop your own techniques. So now the site, actually the mid part of the columella, so you measure like this, you mark, you always develop the marking habits, and then the distance between the two point, that is around the 3 millimeter, and you mark the marker नीचे ला भैया. So this is the invert vertical limb of the inverted, and then if you have a 60-degree angle from this vertical to the horizontal, that is good. And then few millimeter behind, at least 2 to 3 millimeter skin should have for this marginal also for good closing. Now after the marking, I usually use the 11 number blade, and look that how you hold your nose and how you hold your knife. You hold your nose between the index finger and thumb, and you give the counter traction like this. Okay, and then you hold this your 11 number blade just perpendicular to the skin. If you not hold this perpendicular, then you bevel your margin, and later you create a trapdoor deformity, that means overlap the margin. So just stab incision less like, and you give throughout the counter incision just like this and just like this. So on both sides. Now 15 number blade, then you complete this incision like this, and then few millimeter behind this vestibular skin, and on the same another side. Now I make the incision. Now the next important step for complete the incision, what happened? For complete the incision, you need this sharp scissor. This is my sharp scissor. So you pass this sharp scissor from this to the ipsilateral to the contralateral side. You hold your tip like this, and you pass from like this, you spread it, and you keep in your mind that you have the margin behind this, or margin of the medial crust. And suppose if you feel the resistance, then you never force it, you go from the contralateral side. Otherwise what happened, you create the false passage, and you ask your assistant then you are in the right or wrong. You spread it in this like manner, and then complete the incision, because now we have the support. Sometimes we damage the margin in the beginning time, and experienced surgeon also, the margin of the medial crust if damaged, if make the incision, then never panic. You repair that with the 60 vicryl rapids in the letter, but you try to prevent the injury. And then once you complete this incision, then sometimes there is a bleeder here. This is the columellar branch of the superior labial artery, so this one, so I cut it, you cauterize it with the bipolar. Now the next important step for further dissection is छोटा दो ना यार. You use this small wide double prong retractor and one single hook and give the counter tractions like this. कोई बात नहीं, आप पकड़ो इसको. And again, it's a very good technique of Dr. Pond that you hold your seizure just like a pen holding positions, and so simple, you identify first your margin of the medial.
So Sunil,
Sir,
use a single hook to support that medial crus
Yeah.
outwards, because it's more difficult to do what the way you're doing now. Just
Okay.
use a if you've got an extra single hook, so that somebody can hold the medial crus
Yeah,
outwards will make much easier for you.
sir says like this.
No, the other way around. So put this.
Yeah, yeah.
Yeah, that's it. That's it. Oh, use a single hook. It's easier with a single hook. You have a single. Yeah, that's it. If you do that,
You can use. Yeah,
that's
definitely,
it.
sir.
Then now, if it's much easier to find your plane using your scissors.
So this is like in this way, the things that make the dissection easy. This is the margin of the left side medial crust. And now on this side, so after secure your margin of the medial crust from the both sides, then you go upward.
Do you see how much it was easier when you've got that single hook
Yeah,
there? Now
definitely.
keep using that single hook. Don't keep your other person using that single hook as you come around this corner. Backwards, inside. No, don't pull that in.
So along the margin of lateral crust, you go first complete your incision from this side and then another side, because when you go have the good the counter traction like this, then this is you find your site of the incision. Now come on this side, because there are two query by my beginner friend, then what is the lateral limit of your incision, sir? What is message to the junior, then what is the lateral limit of the dissection?
So that
Answer.
really depends on what you're going to be doing. For most of the time, about 2/3 of the way along the lateral crust is enough.
Yes.
It depends if you want to have a big exposure or not. So if you're going to be doing, for example, if you're using piezo or one of these sort of techniques, you might need a much bigger exposure, in which case you may need to get further. And the other thing is, if you're going to be using a lateral crural technique. So, for example, if you're doing a lateral crural overlay where you're going to go very laterally, then you might want to go further still. But I normally do it about 2/3 of the way down the lateral crust, and that's normally enough.
Yes, sir. Absolutely. So it's the important message that at least you should expose your 2/3 of lateral crust. So we complete our transcolumella incision and the marginal incision. Now again, the query by my beginner friend, then what is my plane of the dissections now? So the plane of the dissection, that is when I'm doing this one, my plane of the dissection, that is the suprapericondial. First I get my plane. It, I use classically the 3-point traction technique. वो बड़ा वाला दे दो मेरे को. I classically use the 3-point traction technique. In 3-point traction technique, first this wide double prong retractor, like put it and you revert it, you invert it like in this manner, and one double prong like this and another one on this marginal. And first you getting the plane, and why we use the suprapericondial, because in Indian patient, we have the thick skin patient, so if you go the subpericondial, then you weak your lateral crust. This is the basically message and then theory. All western literature book, they mention that the subpericondial plane, but in Indian scenario, that we have a mostly thick skin patient, but again depend on the patient to patient. Sometimes your patient have a thin skin, so we change our technique according to the patient. इसको लगाओ, इसको लगाओ. So my plane of the dissection, that is the suprapericondial, I expose my lateral crust. You can use, I usually use this Kakir instrument. It's a very good instrument, but I just swap the margin. So I getting the good plane. And you look a important structure of this one, but I think you know all of the name of that one. What is the name of that? Yeah, it's an important structure, and it's a minor tip support mechanism also, because this structure have the horizontal and the vertical fibers. The horizontal fibers, they connect the cephalic margin of this lateral crust, and the vertical fiber connect the dermis part of the soft tissue envelope. So basically it's a dermocutaneous ligament, and the name, the ligament of Pitangui, and so many Western books, they mention about the preservation of this ligament of the Pitangui, but like the Dr. Pond told that they have a long experience of the rhinoplasty, that in Indian scenario we have the thick skin patient, so it's hardly doesn't matter. And I personally experienced that in rhinoplasty we change the entire inner frame, and then how can we keep a structure only one or the same place? Sir, what is your opinion? What is your message for this one? Sir?
I think if you can preserve it, it's no bad thing.
Okay.
I mean, even in thick skin, it does help sometimes reapproximate that super tip area down.
Okay.
So, but it's difficult. And some people are obsessive about it. I'm not obsessive about it. If you can keep it and it's easy to keep, then fine. There's no harm in keeping it. But some people are sort of sit there and are obsessive about it. What I tend to do, particularly if you want to reapproximate that super tip back down again, is just put a ligature across it and then just tie it, and then cut it, and then at the end you can then reapproximate it if you want to.
Perfect, sir. It's a really important message. And now we expose both sides of the lateral crust, and now we go for the mid vault exposure. So when you expose the mid vault, look at the things how the change if you do like this, but the same if you do like this, the counter traction, then you hug with your cartilage part, then look that you expose your mid vault upper lateral cartilage. This is the upper lateral cartilage. You appreciate? This is the upper lateral cartilage. Uh, Actually, you are on the right plane now. Just like when you make a transcolumella incision and then you spread little bit tissue and cut it. You never try to big chunk. Suppose if you have a small injury, then if you have a small chunk of the tissue, then you can prevent. Look that this is the soft triangle part. When we discuss about this LR cartilage, then I explain about then. And first we expose part, we are discussing about the second G step, that means the opening and expose part. Okay, so now if you go upside, then we expose the bony vault. You have a gritty feeling on this bony vault, and you expose again. Then how much go laterally, and what is the upper limit of your dissection? So the upper limit of your dissection, that is the intercanthal line. Okay, and on lateral side, if your patient have a crooked nose, then definitely at least 1 centimeter you should expose. And if you want to like the augmentation of your nose, then you have your pocket, that should be sufficient, not too much, so your graft is snugly fit. Okay, लो अब दे दो, वो इसको expose करेंगे. So हाँ, upper limit is the intercanthal line na? Upper limit, that limit, then no need to go beyond that one. So this is your LR cartilage. This is the, look that this is the right side of the LR cartilage, and we have the different part of this one. But before to discuss, then we open the septum also. If you learn, then this medial most part of this LR cartilage, this medial most part of the LR cartilage, this is the medial crust, and the lateral most part of the LR cartilage, this is the lateral crust, and the part connect these two, that is the intermediate crust. So this medial crust, I have looked at two part. This part that is under the skin, that is the foot plate. This is the foot plate of the medial crust. Okay, and this part, that is the columellar part, because it forms the columellar part of the medial crust. This part is basically responsible for the length of this columella. Okay, and this part, that is the important tip support mechanism. And this foot plate basically rests on this anterior nasal spine fat area. Sometimes what happened in the advancing age after the surgery or the trauma, the fatty tissue they get absorbed and the patient develop it droopy tip. Okay, and this lateral most part that we call the lateral crust, this lateral crust have the two important margin. Look that this is the scroll area. The upper cephalic edge of this lateral crust and lower part of the upper lateral cartilage have this, because there is three type of attachment of the upper lateral and this uh, lateral crust, but most common that is the overlapping like this is this like overlapping, so that we call this around the 15 millimeter this overlapping, this is the scroll area. And the lower margin of this lateral crust, that is the important landmark for the marginal incision. We feel this part, this is the lower margin, so we feel this by cap of syringe, by handle of knife. Okay, this one, this is the scroll area. Look that this is the scroll area, this is my scroll area. मार्कर देना एक बार. So this is the caudal margin of this lateral crust, because when we describe the nose, then the anterior most part, that is the anterior, and towards the maxilla, that is the posterior, and towards the head, that is the cephalic, and towards the mouth, that is the caudal part. So this caudal margin of this lateral crust, that is the responsible for the marginal incision. We feel that one, and this is the scroll area. This is the scroll area. So basically on scroll area, this scroll area is one of important tip support mechanism. And look that this is the resilience of this entire cartilage. He again come in your step. So this is one of important major tip support mechanism. And when we discuss later then different type of the deformities of this lateral crust, and then the part that connect this lateral crust and the medial crust, that is the intermediate crust, and some book mention the middle crust. So this middle crust again have the two part, one anteriorly, this part, that is the domal part, and this posterior part, that is the lobular part. Okay, this is the domal part, this is the domal part. Basically this curve, the dome of this intermediate crust, and this is the lobular part. This patient, this cadaver have bifid tip. Look that bifid tip. When if you examine the earlier, he have the bifid tip. Ideally that should be like this one, but he have a bifid. So this part infratip, basically lobular part, is responsible for the sap of infratip lobule part of tip. Okay, and this domal part of this intermediate crust basically responsible for the sap of the rest of the tip. Because if you have a more distance between this, that you have a broad tip, more than 6 to 8, then you broad tip. And the angulation of this dome, that is responsible for the definition of the tip. Ideally between these two dome, the angle, that is around the 30 degree. If you have the more than 30 degree, then you have a boxy tip. Ideally this angle between these two, that is around the 30 degree. If you have the more than 30 degree, then you have a boxy tip. So these are the different shape, like the broad, you have the more distance, then you have the broad. If you have the more diversion, angle of the diversion, then you have the boxy tip. And sometimes you have a bulbous tip. What is the bulbous tip? Basically that is a ratio, the distance between this dome defining point, interdomal distance, or distance between the inter-alar, yani both of the alofacial junction. So if the ratio is more than 0.6, that we call the bulbous tip. So the broad tip, the boxy tip, and the bulbous tip, these are the different shape of the tip. But who is responsible for that? The dome part of the intermediate crust. So it's really a very important part. This is a smallest part of this LR cartilage, but really it's the responsible for the so many things. Look that, थोड़ा धीरे छोड़ना. Look that this is the anterior septal angle area and this is the dome area. So that is the 1 centimeter anterior and zero point 0.5 caudal that is responsible for the supratip brake. So these are the different part of this LR cartilage, and for ideally uh, good aesthetic pleasing appearance, this caudal margin of this septum that protrude between this medial crust not more than 2 to 3 mm. If more than this, then what happened? You have overhanging columella. If you less than this, then you have the retracted columella. So now we expose the septum. Hello. For the exposing septum, you use these two cartilage holding forceps and you give the traction in the antero-inferior direction. Look that. And again, use the sharp scissor and you spread it and you cut it, spread it and cut it. And you keep in your mind then why I am doing, because I want to find the caudal part of the septum. So spread it and cut it. This is my पेरिकॉन्ड्रियम ऑन अबाउट द मिड वॉल. थोड़ा इसको सेपरेट करो, ऐसे करो, खींचो. सो यू सेपरेट एंड कट इट. Because my dissection on the mid wall, that is the supraperichondrium, so this is my perichondrium, and then you find some glimpse of something. This is my caudal part of the septum. Then you change the direction how you hold your cartilage or you're holding forceps, then the things are changed. Now you appreciate better. This is my septum. So each and everything is important, how you hold your instrument and how your assistant is working in the rhinoplasty. The role of your assistant is important and never the panic. So this is my caudal part of the septum. Again, very good technique of Dr. Pond, that you hold this seizure, sharp seizure, just like a pen holding position, and try to get the plane. And try to get the plane in this way. You can use a periostem elevator, you can use a seizure according to your convenience, but you should be in the right plane. But really, friend, then it's a most important step in the rhinoplasty. Sometimes it's very difficult for getting the plane, especially in a pediatric rhinoplasty, in a crooked nose, or in a revision septum, post septoplasty. So if you not find the plane on the one side, then you change your direction for getting the plane, and do it gently. Then once you getting the plane in the septum, once you getting the plane in the septum, then you develop a sequence how you degloving your mucopericon. That is also important. So first you degloving your mucoperichondrium on anterosuperior part, on anterosuperior part, and then after the anterosuperior part, you just go towards the posterior inferior part. This is the sequence, and then posterior, after the posterior inferior part, then the posterior superior part, and in the last in the anterior inferior part. Stoj wala wo dena. Why in the anterior inferior part? Because in the anterior inferior part there is dense mucoperiosteal attachment in the tuberosity of the maxillary crest area. You can use the nasal speculum also now, and this is a very good elevator by the stores. One end is the sharp and little bit blunt. I usually use this instrument for getting rest of the degloving of the mucoperichondrium. And if you have a perforation little bit or bleeding, then you never panic, you change your direction, because in the rhinoplasty is basically game of the patients. Now you lift up the mucoperichondrium in the anterior inferior, then I lift up the posterior superior, and then in the last in the anterior inferior. And on another side, you can use the nasal speculum also. I just do by the counter traction of the forceps. And you have a gritty feeling when you are a right plane, there is no bleeding. If you are a right plane, there is no bleeding. Nasal speculum. Again, a big bias, a confusion by beginner friends, that then can we separate the upper lateral and and the septum in each and every case, and how we separate it. So first, the important thing, then whenever you separate the upper lateral and your septum, then first you assure that you complete degloving your mucopericardium under the upper lateral. If you not complete separate the mucopericardium under the upper lateral cartilage, then definitely you develop the internal nasal wall insufficiency. So first, look that you assure your that I complete. Look that can you appreciate my periosteum elevator? Okay, and this is the right side, and on this left side, this one. Okay, so once you complete degloving your mucopericardium on under the upper lateral cartilage, then you separate. Now I recommend that if you have a crooked nose case, first you learn then how we I usually use the 11 number blade. इसको थोड़ा सा पकड़ के रखो, and then like in this manner I separate the. So I separate, this is my upper lateral cartilage of the right side, this is my septum. So I separate, and now I have, this is my bony wall, and on the left side I separate on the same manner. So gently you separate it. Now the thing that if you have a crooked nose, then in crooked nose you always separate the upper lateral and the septum, because if you go the dynamics of the crooked nose, on the septum is deviated, septum is twisted. So on the septum there is two types of the force that make more twist. One is the extrinsic force. What extrinsic force? Attachment of this upper lateral cartilage and the septum. This is the extrinsic force that more and more deviated the septum. Another, some intrinsic force on the septum itself, the deviated part of the septum, they pull the force. So in a crooked nose or deviated nose, we complete separate this inner framework just for correction. Obviously, if your patient have only the cosmetic and functionally is good, and in that case you just want to the harvest the septal cartilage, in that case there is no need to the separate the upper lateral and the septum. And again, important thing, the old Western literature book, they mention then whenever you separate the upper lateral and the septum, they always use the spreader graft. So when we mid-vault modification, then we discuss about, there's no need to in each or every case, because there is lot of ethnic variation. In India, we have a very good dorsum, so no need in each and every case. But I recommend then in the beginning, if you separate, then it's good, because you learn the things and your dissection is easy. Look, then give me the nasal speculum after the separation of this upper lateral, and how can you visualize your septum easily. So I recommend, and after the letter, you just suture it by the 40 PDS suture. For the better learning, you separate the upper lateral and the septum. But before to separate, then you use complete separate this one. So now this is the second G step, second golden step we complete. We open the nose, we expose the upper lateral, lower lateral, bony septum, and then the septum, basically the cartilaginous part of the septum. Now the third next important, the septal modification. The common mistake that my beginner friend do in septal modifications, just after exposure they harvest the septal cartilage, they create the L stud, and what happened? after they excise the bump, excise the hump, so you weak your letter AL strut. So the important message to my junior colleagues, then after complete separations, you just examine periosteum elevator. You examine your caudal part and the dorsal part of the septum, and if you have the axis caudal part, if you have the axis caudal part, then first you trim that. So first you trim that, and if you have the axis dorsal part, first you trim that, and then you harvest the septal cartilage. Then you uh, basically create your L stud, and then how much around the 1.5 centimeter, 15 mm anteriorly and the superiorly we recommend. So this is the dorsal part of the septum. This is the caudal part of the septum. The angle between the dorsal and the septum, that is the anterior septal angle. Another we have the posterior septal angle. What is the posterior septal angle? This is the posterior septal angle. थोड़ा सा इसको नीचे कर देना, पेशेंट यूं कर लेना ऊपर, ऐसे कर पकड़ ले, बस पेशेंट को पकड़ ले. So this is the posterior septal angle, angle between this caudal part and angle between this posterior part of the septum, and this is the mid septal angle. But clinically, routinely, the most important, that is the anterior septal angle. If you want to the deep projection in the rotation, okay, so you just know about the anterior septal angle. वो देना, knife देना, give me the knife. So we just trim just like, because this is the lower attachment with the anterior nasal spine. This patient have some axis cadaver have axis caudal part of the septum, so we excise like, if your, so in this way first you excise this one, and then you, how you excise this dorsal part, just like a whole day cartilage holding forceps, and just like, so before to, and in this way, if your patient have a suppose hump, then the cartilaginous part of this bump you excise, and then you can excise this bony bump either by powered instrument, by the rest, or by the according to your convenience. But when your patient have a hump, then you, when you excise the hump, that I think if you do the, some people they advocate the en masse excision of the bump, like the cartilaginous and the bony, but I recommend the component reduction. First you excise this one, and then the cartilaginous according to the that. Now we harvest the septal cartilage, we create the L strut, nasal speculum. The reason behind that, suppose I harvest this septal cartilage, okay, then I harvest, then I create the L strut, and we need at least 1.5 centimeter this one, and 1.5 centimeter this one. And after harvesting this one, if you trim it, then you weak your lower two-third support of the nose. Ultimately the patient develop the tip droop letter, derotate the nose. So you first trim whatever you have the excess amount of the caudal part or excess amount of the dorsal part of the septum. Now you just take this instrument, the nasal speculum, and then you can mark also, देना मेरे को marker. But when you do the more and more cases, there is no need. So at least you preserve like this. This is my marking. This is my marking. And note your, this angle is acute. You rotate it, and sometimes if your septum is twisted and like the buckling and the fracture, then you can make this incision in the fractured part. Okay, then I make the incision like this according to my marking, and then not acute, I move. Then now you change the direction of your prong of your Killian's, this nasal speculum. like you one on other side. So I separate my septum from the superior side, from the inferior side. Now what attachment we have still? Yes, we have the posterior attachment with the perpendicular plate. Okay, because septum consists by bony part by perpendicular plate of the ethmoid, inferiorly by the vomer and the quadriangular septal cartilage, and antero-inferior by the palatine crust and the maxillary crest. Okay, so how I separate that? I usually use this one. This instrument is good instrument, so I detach. I just find go behind, and then I just find where is the junction of this perpendicular plate and the septum. So this is my soft part. Look that this is the junction between the perpendicular plate and the septum. So you just push it little bit, because this is my bony septum. So just like I by multiple perforation, I just break it. Some people they use like the Bellinger knife also, but this is the good way. And you just try to harvest as much as big piece. So this is my septum. This is my septum. This is the superiorly. This is the anteriorly. This is the attachment of this perpendicular plate. Okay. Once you harvest the septal cartilage, then again you examine your septum. Then if your patient have a deviation in the posterior part of the septum, then you do your rest of the septoplasty, and you can harvest this part of the septal cartilage also. This part of the septal cartilage also, if you need, posterior to the posterior septal angle, and try to harvest big piece of cartilage, because we don't know, for the reconstruction we need the lot of cartilage material. So give me the tooth first. इसको पकड़ के रखो, एक को भी लगाओ, यहाँ सेल्फ रिटेनिंग का लगा दो. This is a good instrument by Najim Circus, so there is no need to the hold the someone the dorsum skin. This is the self retaining, and these are the good instrument. This is the self retaining of this lateral crust. So only one assistant, by otherwise someone hold in the throughout the surgery by retractor. Okay, yeah. So look that this is the anatomy of the entire septum. I remove the entire septum. This is my anterior septal, this is my posterior septal angle, this is my mid septal angle, and this part of the septum, that is the posterior to the basically posterior septal angle. So this axis part I trim, and I can use for my reconstruction. Now this is my caudal part. This is basically L strut. So that this is the dorsal part of the L strut. This is the caudal part of the L strut. So clear in your mind. Sometimes what happened, then nasal speculum retractor. Sometimes what happened, your caudal part of the septum have like this. That we call the caudal septum deviation. And sometimes the situation is now like the patient doesn't want the open rhinoplasty, and you have a deviated caudal part of the septum, and the patient come, then I want to correct only this caudal part, I no need to the open rhinoplasty. The situation is difficult. So how you handle it, you learn this thing. If your this is your anterior septal anterior nasal spine, you show the anterior nasal spine. I show the anterior nasal spine. This is my anterior nasal spine. एक मिनट इसको ऊपर पकड़, पेशेंट को यूं करना है. Yeah. This one. This is the anterior nasal spine. This one. So ideally, this caudal part of the septum, that should exact on the midline like this. But sometimes what happened in the caudal septum deviation, this part of the septum either on this side or either on this side. Then what happened? Patient developed the external nasal wall insufficiency, and no one bother for that. Everyone bother for the internal nasal wall, but the patient developed the external nasal wall insufficiency because it forms the medial boundary of the external nasal wall. So how you correct that? Because in that case we not open the basically open rhinoplasty case. Then in that case, then you use first the incision for that. So because just use incision on the most prominent part of the caudal part of the septum, from anterior septal angle to the posterior septal angle, that we call the hemitransfixation incision. But if you, in that case, if you use the Killian incision 1 centimeter behind the vestibular or nasal mucosa, then how can you correct it? So this is the big mistake. You cannot correct that. So basically the incision that should be in the right position. So then if you then after the hemitransfixation incision, then you expose this part of the septum. Once you expose this part of the septum, then you make a pocket by that incision between this medial crust scissor dena. You just create a pocket between this medial crust, just like in this position, both of the medial crust, and then because we already expose it free from the anterior nasal spine, so you move from the right or left in the midline, and you pass a needle from this to this, and you fix by a overlapping mattress suture 30 or 40 vicryl. So without open the nose, you can correct your caudal part of the septum, and then later once you suture it, you make basically the Killian's incision or horizontal incision on the rest of the septum, and rest of just like a usual manner you do the septoplasty. So this is the method when your patient doesn't want to the open rhinoplasty. I saw the lot of cases, my beginner friends, they do a lot of mistake because sometimes the patient come for the army recruitment or something, they have this caudal part of the septum is so prominent. So what they do, they cut it. They make an incision and they cut it. And later what happened? Due to the force of the, because the tip is a lost support, the patient developed a droopy tip. So I think you never injustice to the patient. So this is the way. Then how you handle the caudal part of the septum. But in the open rhinoplasty, how you handle, then बड़ा double retractor लेना. हाँ, there is no need to remove. No need to remove the anterior nasal spine. Anterior nasal spine we remove if you want to deproject a nose. Na? We just reposition of this, we refix this caudal part of the septum in the midline. Again, there is different technique to refixation of this caudal part of the septum with the anterior nasal spine. Look that in Asian patient, you know, the anterior nasal spine is so thin or deficient or weak because we have the Platerine nose. If the same patient is, you know, the Caucasian nose, then he have a so prominent anterior nasal spine. So you can make a hole in this anterior nasal spine by a Linderman burr or by a sharp instrument, and then you pass a thread from this to this and you can fix. But it's too difficult for a beginner, my friend. So the very easy method by Dr. Pond, that is a very easy method. Then you just use this 40 PDS suture. This 40 PDS suture, you pass through the periosteum of the anterior nasal spine. Look that. This is my needle. This is the periosteum. And you can lift it like the, look that. And then you pass this needle from this side to the another side. You can fix it directly or in the figure-8 fashion. So it's so easy methods. In the rhinoplasty, the things to make easy, not complicated. And no need to your Linderman burr or something. So you suture it. You use usually whenever you do the rhinoplasty, when you fix the any graft or any structure, at least you use the 3 knot and you use the 40 PDS suture. This polydioxanone suture have the long the 180-day half life. So this is the third step of basically open rhinoplasty, like the septal modification. So before to do the like the different type, the osteotomy or something, you always first you stabilize your septum. If sometimes what happened, then you accidentally we damage this keystone area and septum is already defixed, detached from this, so septum is completely free. So at least first you fix your caudal part of the septum with the anterior nasal spine. Okay. No, the things this is also a important message or a very good questions. Then suppose your septum is deviated towards the left side. One side is the convex and one side is the concave. So your incision that should be on concave side. And again, the lift up of the mucoperichondrium, that is on the concave side first. So you assure that one side mucoperichondrium you can prevent and deglowing. Sometimes what happened, you have a so bad septal spur, then on convex side you have, like on this side you have the perforation, but at least you one side you preserve it. So your incision make on the hemitransfixation incision you can make on the most prominent part. And if you have a like septum is midline but rest of the septum is deviated, then your Killian scissors that is only on uh, concave side, if you use, that is the better for us, because then easily you can lift up your mucoperichondrium. There is no need to the both incision. No. Look that. Suppose by hemitransfixation incision you expose this one. So the Killian incision that is not in skin, that is only on this septum. That is only for the septum. Okay, that is only for the septum. So now we move in extracorporeal septoplasty. If the septum is deviated, then we just separate this septum anteriorly completely and the posterior completely, and toto we completely remove the septum outside, and according to your desire we reconstruct it and again put it. But it's my message to my junior colleagues then, because sometimes in some big meetings and some advocate the extracorporeal septoplasty. I think the 95% patient without extracorporeal septoplasty, Dr. Pon have a long series of the rhinoplasty worldwide. I think, sir, what is your opinion and what is your message for extracorporeal septoplasty to juniors?
So try and avoid it is the honest answer, because I think extracorporeal septoplasty, when you're first starting, is complicated, it's risky, and you really need to understand how to reconstruct septum before you start doing that. So even, I mean, I do probably about 250 cases a year, maybe 300 cases a year, and I will do maybe one, maybe two a year. Now, I know in India it's been very much taught extracorporeal by Wolfgang Gubisch, who has been here many times, and he's a absolute genius at doing them. But the problem is that you can get issues with reconstructing the at that keystone area.
Yeah.
You have to have options. So my advice is do it other ways. And I think one of the advantages as ENT surgeons, we have a intricate knowledge of septal surgery. So there are lots of options for us to get these things correct without the need to have to take the whole septum out. Obviously, there are some cases where you have to do that, but as I say, in my practice, it's probably once or twice a year.
Yeah, perfectly. It's a very important message by the sir that there is no need to in each and every patient 6060. In every patient that basically you never rigid on the one thing in the rhinoplasty na, that your work that completed, that is the main thing. Either you do the extracorporeal and but you make the things easy. Uh, Now, before to go the osteotomy, I just demonstrate how you close the incision, because once I cutting this skin, then it's very difficult to the demonstrate for us. So for the closing of the nose, I usually use the five tip suture techniques. In the five tip suture technique, I usually use the 60 vicryl rapid look, that it's a very good suture, and I hold this one between the index finger and thumb, and the first suture between in the center, and then the apex of this inverted V incision like this, and then I use like this. Again, we have this different type of this 60 vicryl needle holder, and you use the three nodes, cut it, one on the central and two on corner. There is no need to hold the skin with the forceps, because sometimes you have developed the scar. So one on this corner, and then cut one on this side. This is the last step basically, but I demonstrate because after that you cannot demonstrate properly and we cannot learn the better way. So this is the third suture. I usually use the five suture for closing this transcolumella incision. And yet in my 10-year career, never see a scar in this inverted V incision. And Dr. Pon also, they told that they really, this is a good technique. I learned this technique from sir. And then another between this central and then this corner suture. And first you pass your needle from this stable skin and then in free skin. This is the fourth suture. Pardon? Yeah? Yeah, skin. Yeah. Cut.
So Sunil, which suture are you using now to close?
I usually use the 60 vicryl rapid, sir.
Yeah, so same as me. So I've actually, because the good thing about Vacorapid is you don't need to remove it, and we've shown in a study that it works every bit as well as using a nylon. That's something you have to remove.
Yeah.
The slight downside is that these sutures hang around a little bit more, and if you've got somebody who needs to get back to work or a social life or something ahead of 2 or 3 weeks that it takes the sutures to disappear, then you might have to trim them. But generally they're very small and white colored, and they don't show so much. But you can use permanent sutures and remove them. I just stopped doing that because the patients, so many patients found them very uncomfortable. I had one clinic where I took out 3 sets of sutures and all 3 patients fainted. So, after that point, I just thought there's got to be a better way than doing this. So we use the Vicorapid. I actually use quite a lot more sutures now. I'll show you when we do the live operating tomorrow.
Yeah.
But
I think, sir, you use on this one also, no?
Yeah, I use that one, and I'll show you. I'll show you tomorrow. But the principle is correct in the sense that you want to go from that sort of stable skin into that free skin envelope, and you want to create a little bit of eversion, which allows the scar to heal better. So if you end up with a scar which is looking perfectly flat at the end of the operation, it might look great and the patients might love it in the sense you got a beautiful scar, but actually that's the scar which is more likely to tend to invert. Whereas if you've got a little bit of eversion of the skin, as it heals, it will actually end up with a flat scar. And these are plastic surgical principles. You have a plastic surgeon with you today who is there with you. And these are the sort of principles which are taught in plastic surgery, which are not really taught in ENT surgery. So, closing scars and how to handle tissue is something that unfortunately in ENT is not so well taught. And hopefully this week we can impart some of that knowledge onto the candidates we have with us this week.
Yes, sir. So that's why the important thing that when you make it this incision, then you 2 millimeter behind. So if you use this suture, then it's easy for you. And for marginal incision closing, I usually use only one incision. But the important thing that when you make the incision, you never enter your needle in your cartilaginous part, only the skin part. You use only the skin part. If you use like this, then it's the wrong method. So I usually use this 5 tip suture technique and one on this one. So this is the closing methods of scissor dinner. Closing methods, how you close the nose, and then we use the stereo strips in the 2 layer. Later, when we do the live cases, then we demonstrate that. Yeah, yeah. Again, छोटी देना scissor. हाँ. The first suture in the exact on the midline from this to this, जो ये नोच है उसमें, ठीक है, from this to this, and the second from this corner to this corner. Okay, between this and this part, paramedian position, we can say the paramedian position. This is the corner, this is central, and this is the paramedian position. This is the third. Okay, and the fourth on the same air. So two on corner, two on paramedian, and one on the centrum. And you can use this one also, like Dr. Pon said, for better. And for this one, I usually use only the one. There is no need to more. The just like this one. Give me the needle there. Just like the, suppose this is the skin and the tissues, like this, deep. Some people use the under one more layer of the sutures, but I'm not used. I use directly on this one. I forget again. So look that. Ideally, this is the lateral crest ना. Okay, and this is the, इसको ऐसे लगाओ एक मिनट. This is the junction. This patient have some deformity. This is the junction between the dome and the lateral crest. It's the dome defining line. Usually the dome defining point fall on this line. Okay, and ideally this lateral crest, they should be like go like this, but he have this notch. यहाँ पे सपोर्ट है, यहाँ पे सपोर्ट है. अब देखो यहाँ पे स्किन पे नहीं है. लुक दैट, नहीं है ना ये सपोर्ट. यहाँ पे स्किन के सपोर्ट है, यहाँ बिल्कुल भी सपोर्ट नहीं है. So this is the soft triangle area. Why we have this soft triangle area? Due to the dome notch. Because dome anteriorly, dome जो है उसमें notch होता है basically. So उस notch के कारण ये इसका support skin का lost हो जाता है. That's why we get the soft triangle area. If suppose you have the injury like this in this skin like this, then it creates the contraction, and then later it creates a deformity notching in this area, like say a dog bite or human bites or nail bites. Okay, so it's an important area. So how we prevent it? Like we go little bit, spread it, cut it, and under vision. Clear? Now, soft triangle of this skin part, this skin part, this skin part, this skin part, because this skin part have some little bit subcutaneous tissues and very dense skin to skin approximation. So now we open the skin. ऐसे पकड़ो. After the basically infiltration, then the opening, and then the basically septal modification, we going to demonstrate the how we modify over the mid vault. This is a cadaver, so we cut this skin not in the live patient. So for the modification, seizure dena, for the modification of this
Just to
bony
be
wall.
clear, this is not an extended open approach. This is, you don't do this in real life.
Yes, sir.
Just in case somebody thinks, oh, God, this is a good way.
So for modification, this bony vault, we have lot of procedure like the osteotomy, like the osteoplasty, like the osteotectomy. But the most common we use the osteotomy for modification of this bony vault. So first that what is osteotomy basically. So if you define the osteotomy, then osteotomy basically is a control fracture of this nasal bone. Control fracture of the nasal bone and frontal process of the maxilla just for getting the desirable width of this bony vault. And there are different indication of the osteotomy, but before to learn the different indication of the osteotomy is also one of a major basically complicated step in the rhinoplasty. Why? Because while we performing the osteotomy that we cannot see it, we just only feel by your tactile sensations. And another that make the osteotomy is complicated, that is the uh, thickness of this nasal bone, highly variable nasal anatomy. There are so many patients, the both side of the nasal bone length are normal, width are not normal. On the same side, if you compare the thickness of the nasal bone in nasofrontal suture area is the thickest, and is around the 7 mm in this area. If you come on the exact on the mid part of the osteotomy pathway, that is around the 2.5 mm. But if you come that on the 2.35, that is, if you come on that side, that is around the 2.45. So this is a lot of variation in the thickness that make it a more complicated. So for understanding the proper osteotomy, you have to complete knowledge of the morphology of this bony vault, morphology of this attachment, and then about the aesthetic, then need or not of your patient, and then the different type of the osteotomy, sequence of the osteotomy, and then you have to knowledge which osteotomy you use. Either you use the guarded and the unguarded, and about the surface marking, then you can do a successful osteotomy. So first we discuss in brief about the morphology of this bony vault. This entire bony vault, that consists by a pair of the nasal bone and the 6 important attachment. Center we have the this nasal bone. Central we have this nasal bone. On both sides, I just expose only one side. Center we have the nasal bone, and the superior, anterior superior, we have this lacrimal bone, and posterior inferior we have the frontal process of the maxilla. Marker dena. And superiorly we have this nasal process of the frontal bone, and inferiorly we have the upper lateral cartilage. So these are the important attachment, and underneath we have the bony septum. So this is my nasal, this is my mid part of the nasal bone, and this part is the nasal bone. So you clear from your mind that this is not exactly, this is the basically the part of frontal process of the maxilla. This is the part of the frontal process of the maxilla. So basically the bony vault formed mainly by the frontal part of the maxilla and then the nasal bone. Now the size of this nasal bone is varied. If you compare the size of the उधर नहीं करेंगे पूरा. The size of the nasal bone in the nasofrontal suture area is maximum that around the 14 mm. But if you come on the down in the mid part, that is again is around the 12, and if you go down, then again raise. So uh, this variation in the size of the nasal bone, that is responsible for the shape of the nasal bone. We have a hourglass shape of the nasal bone because in the nasofrontal, that is around the 14, then 10, and the 12 and this shape of this nasal bone that is responsible for the dorsal aesthetic lines. What is dorsal aesthetic line? The curved unbroken line from this medial end of this medial canthus to the tip defining point. So what is the clinical importance of the dorsal aesthetic line? Then dorsal aesthetic line show the contour irregularity of your bony vault. Either there is if there is a excessive curving, that it means there is over wide bony vault, or if there is narrow, that you have the pinching of the mid vault. So this is about the size and shape of this nasal bone, and the length. If you compare the length of the nasal bone, around the 2.5 centimeter. The length is 2.5 centimeter, but the thickness is the different. So this part, the thickness is maximum, and then again it taper it. So this part act as a cantilever. पूरा nose इससे पकड़ा हुआ है. The entire nose hold by this part. So we never enter in this thick part. Sometimes the nasal bone have very short, very short. Then obviously what happened? This upper lateral cartilage is long. Then meanwhile, your osteotomy, this nasal bone is very prone for the fragmentation. बहुत बार बार उसके टुकड़े हो जाते हैं. So what happened? This upper lateral cartilage lost the support and they inferiormedially collapse. The patient developed the inverted V deformity. We say that inverted V deformity. Inverted V deformity, mostly in that patient, they have a very short nasal bone and the long upper lateral cartilage. So during the osteotomy, if the upper lateral this nasal bone is fractured, then the lost in at support in the keystone, peripheral and the central keystone area. So the patient developed the inverted V deformity. Now, after the length and the thickness, we discuss about this keystone area. So we have the different type of the osteotomy. Either the medial osteotomy, one is the lateral osteotomy, one is the intermediate osteotomy, and another is the transverse osteotomy. These are the different type of the osteotomy. But never try to like panic about this one. कोई रटने की जरूरत नहीं है. Look that this is when we do the osteotomy on the most medial part, then is the medial osteotomy. When you do along the lateral most part of the this bony vault, that is the lateral osteotomy. And between this center, that means the median and lateral, this is the intermediate osteotomy. And when you mobilize this part, that is the transverse osteotomy. If you discuss about the indication of the osteotomy for the medial and lateral osteotomy, the indication is almost same. When you have a deviated dorsum, you want to the narrow the over wide dorsum, or sometimes when you in a narrow nose, like a pinching nose, sometimes you for the widening of this bony vault, we need the medial or lateral osteotomy. So these are the different osteotomy, but the goal of all these osteotomy is the same. Just we reposition of this nasal bone according to your desirable width. Okay. So before to the osteotome, one important thing you have to knowledge of the osteotome also. I usually use, there are two types of the osteotome. One is the straight versus curved osteotome, and another is the guarding versus unguarded osteotome. दोनों osteotome देना मेरे को, guarding और unguarding. So this osteotome, this is a curved osteotome and guarding osteotome. This osteotome have the two end. This end is the guarding end of the osteotome. This is the cutting end of the osteotome. Okay, this is the medicone. This is the medicone instrument. So this is the cutting end. This is the cutting end. This is the guarding end. So when you do osteotomy, then this side is the outside. But some people use the guarding and some the unguarding osteotome. But literature says then when you use the guarding osteotome, that it damages more soft tissues, periosteal attachment. So the patient develop the later more ecchymosis, bruising, swellings. When you use the unguarding osteotome, then the less. But on the other hand, when you use this guarding osteotome, then you have the advantage, because throughout the procedure you can palpate this guarding end and you exactly know where you are working. So Basically, this is the advantage and the disadvantage of the use of the. I usually use the guarding end. So first we discuss about the median osteotomy. For median osteotomy, like for each osteotomy, when you do, then you know about the where you engage your osteotome and indication and the osteotomy pathway. First you know, then indication. Either my patient need or not the osteotomy. Sometimes there is a difficult situation that when you examine your nose and you feel that this patient need the osteotomy. But if your patient says, "Oh doctor, I no need I just want the tip work," so you avoid it. What the patient want. If your patient is happy, then we all happy. If your patient is not happy, then there's nothing. So ideally, when you need or not the osteotomy, this is a grossly like this width of this bony vault, because the this bony vault have the two width. One is the bony base width. What is the bony base width? That means the distance between the two frontonasal process of the maxilla on the both side. This is the bony base width, and the distance between this nasal bone, that is the dorsal width. So if this bony base width is more than 80%, around the 90-95 of this ala base width, then you need the osteotomy. Okay, for the narrowing. Uh, Look that this is the dorsum, this is the base of the nose. Okay, this is the nasal bone, this is the frontal process of maxilla. So the distance between this frontal process of the maxilla and the distance between the frontal process of the maxilla, this is the bony base width, because some bony base width, and the distance between uh, this nasal bone, right nasal bone and left side nasal bone, that is the dorsum width. You know, sometimes what happen, if your patient have a over wide bony base and your osteotomy is higher, then what happened, you create a stair step deformity, because but the lower margin is feel just like a stair, so you create a stair step deformity. Okay, so क्या फिक्स नहीं हो रहा, अब ठीक है, ठीक है, now is good. So this is a very good instrument by Medicon 3 mm straight osteotome for the median osteotomy. So where you engage this one between the, this is the upper lateral, between the junction of the upper lateral and the bony septum in rhino area like this, and then little bit just come outside. So throughout the procedure we can feel like this. Okay, so first you clear that where you engage your osteotome. So actually we engage it in the parasagittal manner, paramedian, not exact on the midline. Look that this is the midline. If we go osteotomy like this is the midline, but we actually do like this. So this is the paramedian osteotomy. So this is an important message to my beginner friends that never buys about the paramedian and the median osteotomy. This is the paramedian osteotomy. Now you ask your assistant, then you use the two tap technique, tap 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 tap, just like this one, tap 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 tap, stop. So now the pathway, you can go either, you can go the straight manner, and you can go in the 15 to 20 degree fading position, superior oblique manner. Okay, so I just go the straight, tap 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 tap, हाथ नहीं आना चाहिए वहां पे, दिखना चाहिए सबको, हाँ, tap 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 tap, stop. So like a patient, like if you keep your hand by index finger throughout the procedure, you feel, and never enter in the thick part of nasal bone. The upper limit is the nasium, never go beyond that. Tap tap, automatically you feel when you enter in the sound of the osteotomy change. Tap 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 tap, stop. So look that What I did, that I just separate my this upper lateral, I separate my nasal bone right side with rest of the bony septum. So this is the right side paramedian osteotomy. Now, sometimes when a patient have a crooked nose, then you have a more and more chance of the disruption of this keystone area, because septum is sometimes this septum is ossified and septum is fall during this osteotomy. So another very good technique by Dr. Pawan, that when you enter, this is the transvestibular paramedian osteotomy. So look that, then you pass this, like you go like this, like this, like this, like this, and then you engage just few millimeter above the keystone area. Tap tap, धीरे से मारना. Tap tap, 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 tap tap. So look that. Can you appreciate my osteotome? Mar, mar. Here, this one. Tap tap, tap tap, tap tap, tap tap, tap tap. मार जाओ उसमें. Tap tap. Now you appreciate. Tap tap. This one. Tap tap. So what we do, we preserve this keystone area. So by the transvestibule, if your patient have a crooked nose and you look that, you presume that the keystone area is maybe damaged, then you use this the different type of the transvestibular paramedian osteotomy. So this is my osteotome. This is my keystone area. We actually open the keystone area later when we do the mid wall. So this is my osteotome. So this is the another methods of the paramedian osteotomy. Sometimes if you use like in the superior oblique manner, then your direction is like this. Marker dena. Your direction is like you engage it and your direction is just like this. So in that case, if you need if you want to mobilize this part of the nasal bone, then you use extra, no need to the extra transverse osteotomy. But if you go sometime straight and your root of the nose is deviated, then you need the transverse osteotomy. So this all about the median or paramedian osteotomy. Now, most frequently used osteotomy is the lateral osteotomy. So for the lateral osteotomy, Dr. Pons sir, you want add on something more about the median paramedian osteotomy?
No, I think you demonstrated it very well. That's fine.
Thank you. And for the lateral osteotomy, the two things are important. What two things? One is the approach. Either you go the external perforating technique or the internal continuous manner. So approach, and the second important, the pattern of the osteotomy pathway. Because my junior friends, they bias about they that high low to low. What is that? So first you clear these two things regarding the lateral osteotomy for proper understanding of the lateral osteotomy. So I usually do the internal continuous lateral osteotomy. Okay, so first one side we demonstrate the internal continuous and on another side the external perforating. So we clear first, okay, and give me the वो देना right side का osteotomy, दोनों एक साथ देना. We, this is the right side lateral osteotome and this is the 3 mm medicone. This is the right side and this is the left side. There is a common also that you can use on the both side, but I recommend then you purchase right side and left side guarding 3 mm osteotome for lateral osteotomy separate. Okay, because in this you have this guarding end, then that is a good. Now first you infiltrate if you need, because there is a lot of time to the infiltration, so at the time you can infiltrate. And then first where you engage this osteotome, okay, so then for engagement of this one, just you use this nasal speculum, and then you identify your head of the inferior turbinate. This is the head of my inferior turbinate, anterior end of the inferior turbinate, this one. So just above, just above the head of this inferior turbinate, you make the 3 mm horizontal incision. I make this 3 mm horizontal. Can you see? This is 3 mm horizontal incision. So this is the site of engagement of my osteotome. Okay. Now, how you engage it? You engage like this, not like this, because this guarding end of osteotome that always outside, lateral side, and the cutting end that is the inside. So you engage like this. You first scrape it, you scrape it, and you feel a gritty feeling, and then again you hold in a horizontal, like vertical position, not like this, like horizontal position. Why? Because like we discussed the earlier, the next important point for the lateral osteotomy is the pattern. So in pattern we use the two words, one is the high, one is the low. So my friend, high that means towards the dorsum, low that towards the maxilla. Okay. Initially, when the osteotomy is discovered by Joseph, then the pathway, he engaged the osteotome in the lowermost part of the piriform aperture. Lowermost part of the piriform aperture. What is the piriform aperture? Is the bony opening in the premaxilla of the nose. That is the piriform aperture. And on this piriform aperture, we have a central, just like a spine-like structure in the premaxilla that we call the anternasal spine. Okay, so he used his osteotome and the lower post part of the piriform aperture like this, and throughout the procedure like this, like this, like this, and he on uppermost part just on the low pattern. So consequently, when people use this technique, then Webster realized that uh, when we damage this area we already discussed, then what happened? If you damage the attachment of this inferior turbinate, then the inferior turbinate is medialized. So we engage this osteotome higher. So we go higher. Okay, we go high and then go low and then again high, because if you enter in this thick nasal frontal area, then what happened? That part of nasal bone is free and you create a rocker deformity. What is rocker? The rocker means, meaning, this is the rocker. That means one thing is the forward and one thing is the behind. So this part, upper part of this nasal bone that comes laterally outside, that is the rocker deformity. So for prevention of the rocker deformity and preserving the Webster triangle area, we change the pathway of the osteotomy. What we change? That the, like we engage this osteotome just above the anterior end of the inferior turbinate, so we preserve the attachment of the medial turbinate, and the attachment also the lateral end of the inferior in this upper lateral cartilage. This is the upper lateral. So the upper lateral end we can preserve the attachment. We can preserve the Webster triangle area. Now you use the two tap technique, and look that you hold your nose like this, and this thumb throughout you feel like this guarding end. Nasal speculum देना. Love. Love. Two tap. Use that two tap technique. Tap tap, tap tap, stop, and go gradually down. Go gradually down. Tap tap. So first we engage this one. Go down, go down, go down, go down, go down, go down, and once you come just like a flat in parallel, then you change the direction of your hand. I earlier hold like this one, then I hold like this one. Okay, you change your direction of the hand, and now we see that where our osteotome tooth force देना. So where we are actually working, so you clear this concept from your mind. Seizure देना. Seizure or periosteum. The standard pattern, that is the low, high, low, high, high, low, high. This is the standard pattern. But sometimes if you have a over wide bony base, then you use the low to low. When we need the more movement of the nasal wall, then you use the low to low. But there is different view. Recent literature, they doesn't bother for the Webster triangle. In the big rhinoplasty meeting they discuss, but I think you should follow first the basics. Pardon? Yeah. Ah. Yeah. When we use the high low high, then we preserve the attachment of the lateral end of the upper lateral cartilage, and the attachment of the inferior turbinate also we preserve. No, 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 look that. I show you. I show you. You clear this thing. This is the advantage in the cadaver. Now you clear this thing from your mind. If you go from the outside now, marking dena, this part is the Webster triangle area. And if we come on the inside, nasal speculum, look that we are above this area, because this is the attachment of this inferior, this is the inferior turbinate, and the attachment of the inferior turbinate, if we go like this, then we damage the attachment of this one. Come on this side, look that if we go from this to, then we damage the attachment. But if we go higher, then we leave the attachment. Okay. No, because the attachment is preserved na? Because the attachment is preserved. If you go like this, then that. But look that where we are working. Yes, where the attachment is end, then about top part of the attachment. Mark. Yeah, 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 yeah. Stop. So look that when you come down gradually and just come down the parallel, then your osteotome is properly engaged. Earlier you hold like this, then you hold like this, and where we are working, look that my friend, this is my osteotome. Tap tap, tap tap, tap tap, tap tap, tap tap, tap tap, tap tap. Look that the sound is then again important thing. And in a study, there is a lot of study. The pathway of this lateral nasal bone, the pathway of this lateral osteotomy, the mid part of the pathway that have the thickest part, the proximally and the distally, that is weak nasal bone or this frontal process of the maxilla, but the mid part, that is the thickest. So sometimes what happened, that in this stage also, when you do the osteotomy in a young man, then the osteotome is displaced. So you hold this guarding end properly, otherwise this displaced outside and you go outside like this one. This is a common mistake by my beginners in the internal continuous lateral osteotomy. So throughout you palpate this, and what we doing then, over part or pathway of osteotome, that not through the nasal bone. You got my point? You clear this point? Then in lateral internal continuous or the external perforating osteotomy, we fracture the frontal process of maxilla, not nasal bone. Tap tap. उसमें आना चाहिए, इसको मार. Tap tap, 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 tap tap. No, frontal process. What we want to do, we want to, we want the movement in this bony vault. So how we get the movement? We destabilize surrounding attachment from the rest of the maxilla, from the rest between the internasal bones, from the superiorly with the nasal process of the then we get the desirable width na. So we just destabilize it, we detach from the rest of this maxilla part. Tap 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 tap, move, tap 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 tap, धीरे 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 धीरे. No, 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 no. This is you got. This is the suture line. This is the nasal bone. That's why I clear the anatomy. This is not nasal bone. This is the frontal process of the maxilla, and this is the nasal bone, and this is the nasal suture between the nasal bone and the frontal process of the maxilla. This is the suture line. Give me the marking. So this is a very important thing. You clear it from your never bias. This is the nasofrontal suture basically, and your pathway for the lateral osteotomy along the nasofacial junction. This is the nasofacial junction. If you mark outside, then the junction between the nose and the this cheek. This is the nasofacial junction. So your pathway is along the nasofacial junction, not through the nasal bone. We later discuss them when we do the intermediate osteotomy. Then we discuss about the sometimes we need. No, no. If you go down, then tap, 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 tap. So now once you reach around almost at the, this is my medial canthus. Once you reach at the level of the medial canthus, then you just change and again go the high. First high, then low, and then again high. So I change the directions like this. Tap, tap, tap 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 tap. Look that I change my directions. Tap 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 tap, hold, tap 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 tap. Now after the reaching this osteotome on this just above the near the intercanthal line, then next important step, on the left side you rotate it on the clockwise manner like this, and when you rotate it, then this nasal bone is free from the rest of the attachment. So now my this part of the frontal process of the maxilla is free from the rest of the attachment. Okay, so this is the lateral internal continuous lateral osteotomy. Okay, now if you do this on another side in the external perforating manner, then again the pathway or where you engage the osteotome. For the external perforating, we usually use this 2 mm. I usually use this Medicone 2 mm osteotome. Okay, and then you make a stab incision in the nasofrontal. Lavo dena, marking dena. So this is the nasofacial groove. In nasofacial groove, this is the nasofacial groove. So in nasofacial groove, you make a incision, stab incision by your knife. Just like this is my nasofacial groove. If I make the stab incision, then you look that this is the almost same. Can you see my knife? This is the same. But the same work we doing on another side from the outside. So I make this incision and then I engage my osteotome. How I engage it? Not exactly on the 90-degree. We engage it at the 70-degree. Why? When you engage in the 70-degree, then you can prevent the injury of the bony septum. Okay, and then use that true tap technique. Tap tap. आ रहा है नहीं इसमें? हाँ. Yes. Tap tap. उंगली tap tap. 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 Hmm. 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 So now my osteotomies enter inside, and between we have the three or four perforation. The distance between the two perforation, that is around the 2 millimeters for better uh, green streak fracture. Tap tap. 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 Okay, that is a better. If you something can prevent, then it's the better way. Yeah. Tap tap. Multiple perforations. Yes. Tap tap. Tap tap. Tap tap. Tap tap. Tap tap. Okay. By same in step incision. Tap tap. 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 So after that multiple perforation, then you can use the green stick fracture like this. Okay. So then you mobilize your nasal bone. I not completely mobilize this side just to demonstrate the intermediate osteotomy also. Okay. So these are the two methods, either use the internal continuous or the external perforating. Which one is good? There is a big meeting, and there is a big debate that either the external is good, the internal good. Uh, but according to the literature, when you use the internal continuous lateral osteotomy, then you have the damage the periosteal attachment of the bone. So the latter, the patient have the more edema or ecchymosis, but you have the good consistent narrowing. This is the advantage. But on the other hand, if you use the external perforating, then that is the more precise and preserve the attachment of the periosteal attachment of the bone, so that have the less edema later. But in practically, in my experience, in this internal continuous, I never saw the more like the basically the ecchymosis and the edema. But whatever you use the deformity, either the external or the internal, the main thing, your deformity of the patient is that should be correct. Yeah, we discussed that later in the you give some medications for that one. But the important thing, then either you use the external, and sometimes in some patient, we need the one side is the internal, and on the same side, when sometimes the osteotomy we cannot properly do by the internal continuous manner, on same side we need the external perforating also. Sir, what is your opinion for the external is good or the internal is good?
I I personally use internal, as you know. I think they get bruising with external.
Yeah.
They get more bruising, so I don't think it matters. You can do percutaneous osteotomies,
Yeah.
and one of the advantages of percutaneous osteotomies is that you can be quite precise with it. There's a steep learning curve with endonasal osteotomies. But once you've learned it, it's pretty straightforward. The other option is to use a powered instrument. Of course, now we have piezo. I have piezo available to me, but I don't tend to use it for osteotomies because the advantage of piezo, certainly for a young surgeon, is that you can see exactly where you're placing your osteotomies, and it's easy once you've learned how to do them. And it only takes me 30 seconds to do each osteotomy on each side, whereas with the piezo, you actually have to, number one, do a much wider dissection, almost like what you've done now. You've done a very wide dissection. Obviously, you don't cut in the midline, but you do a very wide dissection, so you can see the base of where the nasal bones or the at the nasofacial groove, really where the frontal process of the maxilla is confluent with the maxillary bone. So you have to go really far down to be able to see that area, and then create your osteotomies using the piezo there. But what you're doing is you're going to do a much wider dissection, so they're going to be a little bit more swollen. But with the internal osteotomies, they're perhaps going to be a little bit more bruised. So it's either way you're going to have something which you're going to have to do. But I think one of the advantages of piezo and perhaps the open or the sort of percutaneous osteotomies is that it's a little bit more precise, particularly for young surgeons who are starting out. But once you've learned the endonasal osteotomy and you're confident doing it, I still prefer that technique.
But sir, what is your opinion that if a young surgeon or a beginner, then he start his career from the Piaggio, or first he understand all these by the osteotomes, the basics?
I think it's like everything else. It's who teaches you and how you get confident. I mean,
Yeah.
if you get to learn endonasal osteotomies, it's a quick, simple way of doing it. One of the other problems with piezo is, of course, there's an expense associated with buying the piezo machine,
Yeah.
and then each tip. So depending on which tips you get, they're either single use or maybe you can use them 5 times.
Yeah.
Now, you might argue that, okay, with a bit of you might use it 10 times. But the point about it is they do become blunt as well with time. So, there's quite an expense. I mean, certainly in the UK, if you're using piezo 3 or 4 tips, forget the cost of the machine. Of course, there's
Yeah.
a cost of the machine, but 3 or 4 tips could easily cost something like 30,000 rupees for those 4 tips. So you have to add that onto the cost for the patient, because you have to factor all these things in. So even if you reuse them, it's still probably going to cost the patient about 20,000 rupees worth extra.
And all this special.
So it's something you have to factor in. All these instruments are available, but it's not at no cost. Now, again, if your patients are wealthy and not insured and all the other things, and they're paying for it, then it's probably not a big deal, because that sort of money is not a big sum. But if I don't know how your insurance stuff and everything, whether they would pay for all this sort of stuff here if you're doing insured type rhinoplasty. That's the problem.
Yes, sir. So really, the important thing that how you're learning, how your professor is doing, and how you're teaching is more important. But in spite of that, you first know the basics of osteotomy. So after the internal continuous and the external perforating, we discuss about the intermediate osteotomy. So friends, for the intermediate osteotomy, there is really the indication is the different. For the median and lateral, this is almost same, but for the intermediate, the indication is different. What is the indication of the intermediate? That's like when sometimes your nasal bone is asymmetrical, but one side is the longer and another side is the short. One side of the nasal bone is the convex and another is the concave. One side of nasal bone is the thicker. So when you have a asymmetrical, particularly a crooked nose, in a crooked nose without intermediate osteotomy, it's very difficult to the straightening. And this is a important reason that so many my friends, junior colleagues, that sir, after my lot of osteotomy, the patient still have the deviated nose, residual deviations. So when you use the intermediate osteotomy, then particularly it matter the sequence of the osteotomy. Then if you use the 3 osteotomy, the combo of osteotomy like the paramedian, lateral and intermediate, then first you use the intermediate osteotomy. Why? Yes, because suppose if you use the lateral osteotomy first, then you destabilize your bony mold, and then how can you perform? So first you do the high osteotomy. When you use the multiple osteotomy, then first you use the high osteotomy and then low osteotomy. That means first to the intermediate. Now again, the second important message, that which side to use the first, because suppose your nose is just like this one. Suppose your nose is just like, so this side of nose, that is the concave side, and this side, that is the convex side. One is deviated side and this contralateral side. So which side you do first? this is also a common mistake by my beginner friends. They first do the osteotomy this one. So look that if you do the osteotomy on the convex side and this part that resists this bone, so how can you come on the midline? So first you do the concave side, that means contralateral to the deviated side, because there is a steady. Then if you compare the thickness also on the deviated side and the concave side, contralateral, this part of the nasal bone is the thin. The osteotomy pathway in concave side is the thin. So first you do osteotomy towards the concave side, and then once you finish that one, then you do the osteotomy on the convex side. So this bone allow this convex bone to the midline, just like a open book. You first open the first outer cover and then the rest of the pages. So the sequence and the site is important when you do the intermediate osteotomy. So where do the intermediate osteotomy? The intermediate osteotomy we do the exact the mid part of the lateral nasal wound. Yeah, yeah. But basically, it's usually need intermediate osteotomy on the convex side. But if you need, then you do the both sides. If you need, do the both sides. Then just like a external perforating osteotome, just you mark between the this is the lowermost part of this lateral nasal wall. This is the lowermost part, and this is the uppermost part. So between the lowermost and the upper part, like this, tap 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 again, tap 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 tap. So this is my intermediate osteotomy. Tap 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 tap. So then you can do the green stick fracture like this. Tap tap. So whenever you use the either the use the intermediate like the paramedian like the lateral according to the indication you use. So this is the pathway of this intermediate osteotome. So you can then break the this nasal bone by the just like a green stick fracture. So this is the intermediate osteotomy. Okay. Have you any question about the intermediate osteotomy? And the last that is the basically the transverse osteotomy. Sometimes in spite of the median, paramedian, lateral and the intermediate, the nose is still residual deviation, because sometimes the root of the nose is deviated. So in that case we need the transverse osteotomy in the same manner, just like perforating manner, like tap 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 tap. Okay, my there are so many colleagues then and some so many beginner friends, they are afraid that then when you do the transverse osteotomy then entire nose is collapsed. No, because if you never do the just above the nasion area, just below the intercanthal line, just like tap tap, because without the in transverse osteotomy and if a patient have a root of the nose is deviated, then you cannot correct the root of the nose. Tap tap, stop, tap 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 tap. So now you root of the nose, then you mobilize according to your need, because we free over this bony wart from the rest of the maxilla, from the medially and then superiorly, and then so according to the desired step you can modify this bony wart. And sometimes if your one nasal bone is thick and another is thin, then you use a powered instrument like a burr or something or rest just for the thinning of this nasal bone, that we call the osteoplasty. And by the Piaggio you can do easily, and you can use a big diamond burr also. There is a long burr available just for the thinning of this thick nasal bone. There some people use, so many times I also use the osteoplasty. First I thin the thick nasal bone and then you do the osteotomy. Okay, but the important, the upper limit. Look that again, that this is my medial canthus, and this is my medial canthal ligament. This is the medial canthal ligament, this one. So this is the upper limit, never go above this one. So this is all about the bony vault modification. That is the fourth important step of the rhinoplasty. Any questions, any doubt regarding that, regarding the osteotomy? Huh? Step of deformity, suppose your patient have some over wide bony vault, over wide bony vase. Suppose a patient have a over wide bony vase and your pathway is osteotomy is higher. Then suppose if you go higher, then this part of the nasal bone, this part of the nasal bone, that is feel just like a step, that we call the step deformity. So the stair step deformity, inverted deformity, and the rocker deformity, these are the common deformity that related with this osteotomies. Okay, now we come. Yeah, basically it is passing through the almost the suture between the nasal bone and the frontal process of maxilla. Yeah, this is my frontal process of maxilla. Okay, this is my nasal bone. So almost this is the suture area. Okay, now we come down to the bony, after the bony vault, the mid vault modifications. So for the mid vault modification, uh, we already discussed the important area. So वो देना मेरे को tooth forceps. Medially attachment, that is the important, because medially attached, this is the internal nasal wall area, and look that my mucoperichondrium, that is entirely intact. Okay, so this is the internal nasal wall area. Medially this is the septum, and laterally this is the caudal part of the upper lateral cartilage, and inferiorly this is the inferior turbinate. So these are the boundary of the internal nasal wall area. So look that this is the upper lateral cartilage. This upper lateral cartilage is almost the triangular, and this is the keystone area. This is the keystone area. Once after the spread graft, then we open it, and this is the scroll area, this is the keystone area, this is the internal nasal wall area, and this is the Webster triangle area. So it's a important subserving cartilage. And in my practice, then I realized that most of the post-operative complications by beginners in the septoplasty patient have deformity related with this mid vault. Either the patient have, because they remove this part of the septum, they remove this part of the septum, so the patient develop the settling in the mid vault. This is a common deformity, and sometimes by the after the quadraseptum removal they develop the tip droopy. So for the restoration of this mid vault, we use spreader graft or the spreader flap or some sutures. So the spreader graft, I just demonstrate for the spreader graft. First you know the indication, then when you use the spreader graft, because for every graft we have some important indications. So for the indication for the spreader graft, that is sometimes when your dorsum part of the septum is deviated. Just for getting the straightening of the septum, we use the spreader graft. Sometimes if you have a open roof deformity. What is open roof deformity? Once you have a bump on the nose, and when you excise the bump, not a small one, either you more than 0.5 mm, 0.5 centimeter kareeb. Then when you excise that, then you create a gap between the upper lateral or the bone or the bony septum or the cartilage, that we call the open roof deformity. So for correction of the open roof deformity, Or obviously sometimes we have the inverted V deformity, for correction of the inverted V deformity view. Or sometimes the patient doesn't have any deformity, but he have the internal nasal wall insufficiency. So for improvement the internal nasal wall insufficiency, we use the spreader graft. Or sometimes we have the purely cosmetic purpose for getting the good dorsal aesthetic line, but not more in India, but in Western, because they want the good dorsal aesthetic line, suppurative break. In India, not too much. So these are the different indication of spreader graft. Like any graft, whenever you use in the rhinoplasty, then I think three or four things regarding that graft that is you always keep in your mind. First, indication. What is the indication? First, you know that the indication of that graft, and the second is the shaping, how you make the shape of that graft, and the third is the placement, how you place that graft and how you fix these four, like the tongue, like that shield graft, columella strut, septal extension graft. You these 4 or 5 points. First, the indication. If you have indication, then you use that graft. Without indication, if you use the spreader graft, then it creates the problem. So we discuss the indication and then now make the ideal shape. For the shaping, ideally the length of the spreader graft is around the 20 to 30 millimeter long. The 20 to 30 millimeter long, and around the 3 mm ideally the width of the spreader graft. So this is the ideally shaping of the spreader graft. And then after making the ideal shaping, then how you place. Really, the spreader graft placement is little bit tricky, but because sometimes the graft is fall down again and again. So for prevent this problem, what you do, the upper end of the spreader graft little bit oblique like this, on the another side also like this. You cut it in a oblique manner. So I personally feel that this part, this oblique part, that is snugly fit under surface of the distal part of the nasal bone. So the things make easy. Tooth for something. Thickness is around the 1 to 1.5 mm, and the septal cartilage is the best part. So just I lateral pull this upper lateral and go down, and just this is my distal part of the nasal bone. So when you cut it oblique, then you place it easily in like in this manner. So the things make easy. And same on another side, you place it between the mucoporicondial pocket like in this way, but just under to the distal part of the nasal bone. Now, after the indication, after the shaping, after the placement, the fixation, how you fix the, in mostly in all rhinoplasty, when we fix some structure, then we use the 40 PDS suture. Give me the 40 PDS. But before to the use the suture, you can fix it by the needle. So you fix it by the needle. You can you can fix all 5 structures simultaneous. But for my beginner friends, then I advocate that first you fix these 3 structure. इसको पकड़ना. Yes, below the nasal bone. So this one side of the spreader, this one side of the septum, इसको ऐसे पकड़ो. And then this is the one side of spreader, because the bone is break, because little bit fragile, cartilage is fragile. So in this way, first you fix this 3 structure. Suture देना. So you pass a suture from this spreader.
Sunil, just one tip here.
Sir,
When you have this suture, use a round-bodied needle, because as you see, okay,
Yeah.
this is cadaver, so it's very weak, the cartilage, but it's very easy to cut through this cartilage.
Yeah.
So for this, as you look, you can see it's just falling apart.
Yeah.
So if you use a round-bodied needle
Yeah.
for this rather than a cutting needle,
Yeah.
it's not going to cut through the cartilage. Once you then are going to approximate the upper laterals
Yeah.
onto the structure, then you can use a cutting needle. But for this particular thing, I would use a round-bodied needle, because otherwise the cartilage is quite weak, and it's very easy, as you can see, using a sharp needle to cut through it. So just always use a round-bodied needle.
Yes, sir. I got point. Really, is important. Then sir said, then rather than I use the cutting, first I fix with the round body, and then can I use the cutting. Yeah. So this is a horizontal mattress suture. So by this horizontal mattress suture, इसको यूं पकड़ लो ना, उसको छोड़ दो. Now again the important thing in rhinoplasty, each and everything important. Look, if you fix like this one, then you destabilize it. You fix your knot in your long axis of your knot, and then you use like one and like the two knots again in the this long axis of the. So these things are the important. Like you use the three knots, cut it. At least you should let a 2 mm or 3 mm for prevent the slippage of the knot, and then you fix. So this is the way you can fix the three structure. And sometimes what you can do, then you pass this needle from the right side of the upper lateral, and then from the spreader, and again from the septum, and again from the, these all five structure you can suture. So for fixation of the spreader, you use at least three or the four suture. It's a type of the horizontal mattress suture. Sorry. Height, height of the that means this height with this septum. Okay. So look that if you want to, like, this is a one method also. If you want to the, if you want to the more augmentation of the nose, and if you want to the put the dorsal graft, then your height that may be above the septum, so that it help in the augmentation. Otherwise, just at the level of your upper end of the dorsal. So basically, the things are changed according to the specific type of the anatomical uh, deformity. So I, all five structure I fix, and same, and if you not use the spreader graft, then you same in the same manner the all three structure you fix by this 40 PDS suture. Now it's also important thing, then either you use the bilateral always or the unilateral also. This is also common question by my junior colleagues. So suppose sometimes your patient have a, like this dorsal part is like this one side is the convex and one side is the concave. So you can use a strong unilateral spreader on the concave side just for getting straightening. Either if you have enough cartilage, then you can use the on the both sides. And another, a variation of the spreader graft, sometimes when your patient have a droopy nose or a binder syndrome, and in that case when you use for augmentation a basically integrated L strut like the big dorsal graft, and then one strong piece of the cartilage, and you use like this, then this spreader graft you use little bit longer, just lateral to the strut, just for getting the more support of that strut, that we say that is the extended spreader graft. You can increase the length of the nose also. Or sometimes when you have the post septoplasty case, in post septoplasty case sometimes the almost the distal part of the septum is absent. Then in case what you do, then you just use a fan shaped long graft, like fan shaped long graft. So the upper part of that graft that suture with the residual septum, because that we find in the septoplasty is a little bit dorsal graft, little bit dorsal part of the septum graft. So you suture that type of the graft with the residual dorsal part of the septum, and then you use both sides the extended spreader graft for just reconstruction of this just type of a columellar replacement graft. So this is the different type use of the spreader graft. Yeah. The length that should be till the anterior septal angle area. If you use more than this, like this, if the length of your spreader graft that is like this, that, and this is my strut, then I use as a extended spreader graft. ऐसे पकड़ना. Yeah. हाँ, but you need till that the level of the antenasal spine and the nasal. That is the better. So this is about the spreader graft. We open it. ये remove करो. And sometimes what happened, then if you have a bump on the nose, if you have a good cartilaginous hump, and you exercise the cartilaginous hump, you know, seizure वो देना, एक seizure देना, sharp seizure. Pseudo hump basically, you know, in the rhinoplasty there are some illusions. What is the illusion in rhinoplasty? There is the illusion that means maybe sometimes your patient of the tip is droopy. When you have a long bump, then the nose appear like a narrow nose. So that's why this is the importance of the anatomy of the nose, normal aesthetic parameters of the nose. Then you decide what type of that. So that pseudo bump, that is it. So in pseudo hump, there is no need to the correction. Rather than you augment your tip. So automatically that is the correct. That is the pseudo hump. Give me the knife. So we discussing that after the excision of the cartilaginous bump, after the excision of the cartilaginous bump, then you have, suppose you have this axis part of the upper lateral also. This is my upper lateral. So you have this axis part of the upper lateral also. Then what you do, you want to change the width of this mid vault also. So you separate the mucoperichondrium. You separate this mucoperichondrium from the upper lateral. This is my mucoperichondrium. I separate this mucoperichondrium, and then I rotate this medially and pass the needle dena. I rotate it medially in inward direction, and I fix by a needle and by a same suture you pass the suture. इधर से इसको ऐसे दो. Sometimes we don't have the much cartilage piece and we need the spreader graft, so you can use this spreader flap just as a spreader graft. So the motto is the same, but we can, this is a modification of this, hold this one. So this is a spreader flap. We fold this upper lateral cartilage rather than instead of it cut it, for getting the good dorsum contour and the strength. Yeah, you can, but it altered the width of the, it's altered the, so you Look that in rhinoplasty, sometimes when you use the septal extension graft and you want to the projection of the nose, simultaneously there is unwanted rotation also. That is also happened in the tongue in groove also, later we discuss. So you keep that when you use the new technique, then the indication and the what is the drawback, some unwanted effects. So basically, this is the type of a spreader graft. This is the spreader flap, and sometimes we use just for getting increase the cross sectional area of this uh, internal nasal wall area. We use some suture also. That is the flaring sutures. So flaring sutures, how can you make like this? You pass from this and again from this cartilage, and then again on another side, just to increase your cross sectional area of patency of your internal nasal wall area, and just on like this. So now when you pull it, look that the things are changed. If I leave it, so the flaring suture is a adjunctive or add-on, not just like a spreader, but you can use for excessive increase external cross sectional area of the internal nasal wall. So this is all about the mid vault modifications, and we want to show you the keystone area. uh, Almost. So this is my upper lateral. I try to show the exact attachment. इसको पकड़ के रखो. Yeah. हाँ. That means when you use the endoscopic septoplasty, then yeah. Okay. Huh? You look in the endoscopic septoplasty, until unless you do wrong, na, otherwise the this keystone area is too high, not damaged. And in rhinoplasty is not damaged. In keystone area damage, mostly in my experience, when have a severe crooked nose and the cartilaginous septum is also ossified, and when you do the paramedian osteotomy, because the septum is anteriorly, we also destabilize, and then from in this area, then sir, what is your opinion about the keystone area damage?
Sorry, what about the keystone area dam?
Then in the endoscopic septoplasty, I think there is no chance of the keystone area damage, na?
I think there's a chance of keystone area. It doesn't matter which way you do it, endoscopic or otherwise. It's just you've got to be careful
Yeah.
to leave at least 5 or 6 millimeters at the keystone area to avoid any disruption of the keystone area. But you've also got to then factor into account the fact that you may be taking some of the keystone area down. So, there's lots of things that you have to consider in that keystone area. But, the point about it is you must not disrupt the keystone area, because once you've disrupted it, it's very difficult to reconstruct it.
So this is the attachment. Look that you can appreciate. This is my distal part of the nasal bone. You very well appreciate. This is my distal part of the nasal bone, and this is my upper lateral cartilage. And look that there is overlapping between the distal part of the nasal bone, and this is the uh, proximal part of this upper lateral. So this is the central keystone area, and if you come down, then there is a less and less overlapping. So the keystone area, one is the central and one is the peripheral, but the central keystone area, you always maintain the integrity of this one, because this cartilage otherwise fall down like this one. And suppose if your this area is damaged, your septum is fall down. So if there is a situation like this, that this septum is fall down, but not this rest of the septum is good in amount, and there is a little bit detachment, then you pass a needle from this to this, you can fix it. But sometimes if we completely disrupt and the septum is fall down, then you pass a wide bore needle from this to that side, and then you pass a suture from inside to that, then you can fix. एक बार देना उसको, जाएगा नहीं suture उसमें. So this is the way by you can make a drill hole, or you pass a uh, big needle, and then you pass from this to the another side, and then you pass a suture. There is a suture from the another side, and then you remove that suture from this and this, and then you can tie it. That is not easy, but that is the TTC, trans cutaneous suture. Little bit tricky, little bit tricky. So after the mid vault modifications, now we come to the tip. Suture bo dena, saline dena. For the tip, we already discussed about the anatomy of the tip, but really tip is very इसको ऊपर कर देना. Tip is very complex, because it's too difficult to the getting the predictable outcome. इसको थोड़ा सा ऐसे लगा देना. So first you understand about the anatomy of the nose. The anatomy of the LR cartilage we already discussed. So mostly the normal tip characteristics first you understand, and then you understand about the abnormal tip characteristics. There are 5 or 6 normal tip characteristics, like the volume of the tip. What is the volume of the tip? That means sometimes if a patient have a bigger volumic tip, then volume of the tip, that means the size of this lateral crust. The size of this lateral crust that decide the volume of the tip mostly. And the second characteristics, that is the width of the tip. Width of the tip, that means the distance between the tip defining point, that is the width of the tip. And third is the definition of the tip. So the definition is basically the angulation of this dome. The angulation of this dome, that is this side the uh, definition of the tip. This amplitude of the dome, that is around the not more than 4 mm. And another is the sap. Sap we already discussed, either the broad, bulbous, or the boxy tip. And another, the two important tip characteristics, that is the projection and the rotation. That means the projection, that means the distance, the nose by which project from the rest of the face, like this. So basically a distance between the tip defining point to this alofacial groove. This is the projection. And another is the rotation. What is the rotation? The rotation, that means the inclination. The inclination of this tip from this rest of the face. So we measure this rotation. We measure the rotation in the as a nasolabial angle. Angle between this columella and the upper lip. And the junction of this columella, and this upper lip, that we call the subnasal. If you measure the mid face length na, then one point is the subnasal and another is this the nasion. This is the mid part of the length of the face, and the lower part of the face from the subnasal to the menton, most anterior part of this chin, that we call the menton. So we divide the face, because when you examine your patient, then After the nose, you also examine the relation of the nose with the forehead and the relation of the nose with the rest of the septum. Sometimes your patient have a deficiency in the chin, and then it look appear like a long nose. So you explain these things to the patient that you need the chin modification also. And sometimes uh, your this nasofrontal area, the nasofrontal area is deep, then the nose appears the short. But sometimes if the nasofrontal angle area that is the shallow, then the nose appears the longer nose. So first you know the normal characteristics of the nose, then you decide about the abnormal characteristics. Then you decide the abnormal deformity of the nose. So for improvement of this deformity of the normal characteristic, we need some techniques, 4 or 5 techniques. So 95% tip deformity you can correct by these 4 or 5. What 4 or 5? First is the columella strut, and second is the cephalic trimming, third is the dome creating suture, or fourth is the interdomal suture, and fifth, that is the Adon graft. 95% tip deformity you can correct by this. So one by one we see, and the rest of then the advanced tip technique we later. Yeah, Vijay. Seizure, seizure, columella strut का वो बना, tooth force. धीरे कम कम. ऐसे रहना, टिप पे फोकस करना है ज्यादा. बस बस. Marking the marking. जब नापने का देना मेजरमेंट. नहीं नहीं ये नहीं, दूसरा था ना देना. Knife, knife. Mark. Thank you, sir. So, yeah, it's okay, it's okay. So, you again, we discuss about the 5 tip uh, modification techniques. So first I demonstrate the columella strut. Again, then whenever we use the any graft, then the indication, and then the stepping, and then the placement and the fixation. These 4 or 5 points to remember. So the indication of the columella strut just for getting the projections, just to make a unified tip and getting the good columella step. Okay, and then for the shaping, the ideally the length of this columella strut, that is around the 20 millimeter long. Okay, and the width is around the 2.5 mm, and the thick, that is around the 1.5. So if we discuss, then the warmer part of the septal cartilage, they match all the criteria. So the warmer part of the septal cartilage, that is the best for the columella strut. And this is a good habit. Then first, after the making the shape, then you hold this medial crust like this and like this, give the counter tractions, and this sharp scissor, you look that you spread it and like you spread it and like spread it, and you make a pocket. Because if you discuss about the columella strut, the placement, we have the 3 step. First for shaping, and then you create a pocket, and then insertion and the fixation. So now the how much we insert inside, how deep the pocket, that is also important. If you create a pocket exactly on till at the level of the anterior nasal spine, then when you put this columella strut, then what happened? Then later the patient have some problem. The patient say, "Oh doctor, whenever I move, that there is a clicking sound from this columella." So what you do? You just left little bit tissues between the antenasal spine and the column base of the columella strut, and you can mark between the mid part of the columella strut, and almost the marking just below the mark, you insert in the pocket just like this. You pass this one like this. So you pass, this is my marking area, this is my marking area, so almost you pass the marking area in this pocket. And then after the passing this one, then you hold this, and then you pass. How you place it, after the placement, how you fix it, that is important. So you pass the needle from one side to the another side. When you pass the first needle, then this little bit tricky, but you keep the patience, but never do the wrong. So in this way, you pass the needle, but the important thing, when you pass the needle, give me the another needle. If you pass the needle just like this one, in this way, that is the wrong method. The needle, that should be the entry and the exit on the same plane. Otherwise, you uh, fix in not a right position. So that means your both needle, that should be in the horizontal direction. You pass like this, because the same thing, when you put the suture, then the entry and the exit is that on the same plane. So now the suture, ये हटा दो, because now the skin is dry. So then how you fix this strut? Then you pass this needle from one side, and then in the strut, and then from the medial crust. So the entry and the exit of the needle, that should be exactly on the same plane. And again, from this side Initially you pass you one to one structure, but once you do the more and more cases, then all three structure you can pass the needle. Some people use the directly the skin to skin fixation, but I think you should try to avoid, because later the patient feel the note, and this note is subcutaneously. Another good technique by Dr. Pond, that the note that is inside of this one, that is also a good method. So you fix then this note by double like this, and again you not fix like this one, you fix this note along the long axis of your columella like this, not like this. This is the wrong method. So you hold like this and you fix it, and then two or three sutures you need for your columella fixation. This is strut fixation. Yeah, the skin cover. This note is subcutaneously. The skin cover this note. So in this way, you fix this your columella strut, uh, like one more, or at least you need the three suture for fixation of the columella strut. Okay. Anyone have the any questions about the columella strut? That yeah. The purpose just for getting the projection, and then for columella shape and the stability of the basically the columella. But when we discuss later, when we need the lot of projection that we cannot correct by the columella strut. Now the next important, that is the cephalic trimming. The upper end of this columella strut, that not beyond the dome area, not beyond the dome area. That means this is my dome. So upper end of that is columella strut, that is not beyond the dome area. Okay. So this is about the columella strut, just for getting the projection. And then uh, regarding the, if a patient have regarding the volume deformity, that means a big volumic tip, and if a patient have a excessive long this lateral crust, then just for decrease the volume of the upper lateral cartilage, we use the cephalic trimming, just to reduce the volume of this upper lateral cartilage. Now the important thing then, how much we reduce. So how much is reduced, that is not important. The important thing, 15 number blade, how much we preserve. Okay. Rollin Daniel and Dean Toromi, there are a lot of the books, they mention the 6 mm, but in Indian scenario, we need at least 8 to 10 mm, because we have the skin patient. So then first you measure it. This is a measurement caliper. Then if you compare in this patient, look that this is around more than 10. This is around the 13 mm. This is around the 13 mm. 13 mm. So if you have the 13 mm, then just I demonstrate then how you do it. Then you measure and mark around the 10 mm, and just like you give the marker, because if you develop the marking habit, that is a good thing. Then is the marking habit is a good. So you mark like this after the measuring, like this, and then you make a step incision. Then you make a step incision. Pakdo, hold. You make a step incision like this, but you never, the dome notch that should preserve medial to lateral, and then you separate it. You can use the infiltration also on this side, just for getting the hydro dissection. But if you do the more and more case, and it's your according to your convenience, you can do this work, and you preserve the vestibular mucosa. So you separate this one like this, and then if you appreciate, this is the branches of the lateral nasal arteries. This one. This is the lateral nasal arteries. So then we cut it. But again, my beginner friend, they have the question in the mind that when I exercise my this cephalic part of the lateral crust, then I damage the scroll area, because the scroll area that is a bit far away, so we not damage the scroll area. So in this way you can reduce it. Sometimes what happened, you want to rather than you cut it, you flip it, then you turn over it, you make a space under this one, and then you pass this part under this lateral crust, lateral turn over. Okay, when you want strengthening of this part of the lateral crust. So this is the cephalic trimming, and this part of the exercise part of the lateral crust is very flexible, so you can uh, preserve it for the cap graft or something, because this is a good malleable graft. So this is about cephalic trimming, just to reduce the volume of the large lateral crust. Now next, the dome creating suture, just for getting the more definition of the dome. So the dome creating suture, when you put the dome creating suture, then you can use the 50 PDS or the 40 PDS. If sometimes if you have a strong dome, strong lower lateral cartilage, then you can use the 40, either the you can use the 50. So look that how you hold like this, in this manner. This is the cartilage holding forceps. You always have this forceps, because not a normal tooth forceps. This cartilage holding forceps a good serration, so have the good grip. So you hold your dome just like this, and you pass your needle from the medial to the lateral, and then again the lateral to the medial. You ask your assistant, he hold in this forceps, and then from thoda पीछे, again lateral to medial. So the knot in the dome creating suture, that should be on the medial side. Sorry guys, cut through हो गया. So it's a type of a horizontal mattress suture. छोड़ो छोड़ो. It's a type of the horizontal mattress suture, creating for the more dome definition. Ideally, for good aesthetic pleasing, we need the two tip defining points, so not exactly anteriorly, just behind, few millimeter behind. So we now put the knot. So now the things are changed. Look that we getting the more definition of our, and you use the three knots, cut it. So this is the dome creating suture or the intradomal suture. That is the same thing. Now the third technique for modification of the tip, that is the interdomal suture. So for the interdomal suture, you pass from the one side to the another side, and then so what is indication of this, what is the purpose of this interdomal suture? Just to decrease the width of the tip. Every this technique have their motto, the purpose, Like the columella strut we use for getting the projection. The cephalic trimming we use for decrease the volume of the lateral crust. And the dome creating suture we use getting for the more definition of the tip. And the interdomal suture decrease the width of the tip. But the important thing that you never too tight, because for the aesthetic good pleasing appearance we need the two tip defining point, otherwise you create a pointed tip. And if you the lose it, over lose it, then you create the over wide tip. So the knot should be not too tight or not too loose. So this is the interdomal suture. So my junior friends that they never bias about the intradomal and interdomal suture. For your remember, then intradomal and interdomal in just like a interdomal a intercity express that they connect the two dome, that is the interdomal. But the intradomal is the same dome, that is the dome creating suture. Okay, so this is the fourth step of technique for modification of the tip. And after the columella strut, after the cephalic trimming, after the interdomal suture, one that we use the add-on graft for getting the more refinement of the tip. We use the different type of the graft like the sealed graft, like the cap graft, like the diamond graft, umbrella graft. But the most common use that is the in Indian scenario, that is the sealed graft. So how we use the sealed graft? Sealed graft. The just like the seal, the shape that the seal graft. ये दे दो ना मेरे को ये काम ठीक. So again the indication and the shaping and the placement and the fixation for the sealed graft. The indication of the sealed graft, then sometimes in the revision case and a so thick skin patient when your infratip part of the infratip lobule is excessive and you need some like the derotation of the nose and getting the more support, then you use the sealed graft. So in the sealed graft, how we make the ideal shape, ये संभाल के रखो. So according to the need we use just to make just like a sealed. So this is the sealed graft. Didn't they na? So this is the body and this is the shoulder of the sealed graft. So now first step indication and then shaping, and the third the placement, how you place it. So you pass a needle like this, you pass a needle like this, and then because we don't have the sutures or something, otherwise this have a good stable things, then you pass like this and you place like this. So the shoulder of this sealed graft that we suture with the dome part of this middle crust and few millimeter above this dome area. When we suture it, like how we suture it, like in this one, इसको पकड़ो पीछे से, like we pass the suture, इसको नीचे से पकड़ के रखो ग्राफ. In this little bit difficult because the things are destabilized. Mostly we use in the revisions cases or so thick is in the patients, we use the sealed graft. So we fix like one suture here and another suture on the cut it. Like when you look that you when you have this some some nose have the parrot nose, the axis part of this infratip lobule, or sometimes in spite of the lot of columella strut and you need still you some more strengthening for the central foundation, we need more projections and more strengthening of this part, then we use the spreader graft. But the problem is that spreader graft, that this part is just above the this dome area. In the thickest skin patient, what happened later? This part is medially rotate like this. So just counteract to this problem, we do just small part of the another graft, suture देना, ये graft देना, like this, 15 number plate. Just to counteract this problem, we use another graft just anterior to this needle, just like you pass the needle and just anterior to this, just anterior to this excessive upper margin. So this part of graft that support this axis part, okay, this is a type of a cap graft. This is the shield graft, this is the type of the cap graft. No, this is just like the rectangular, square shape mostly, but the margin that is just like bevel. So then this part have the good support, okay, but they all tip add-on graft just for getting some refinements, not just change the structural component, okay. So by these 5 tip technique, like the cephalic trimming, like the columella strut, like the home creating sutures, intradermal and tip defining point, we can modify basic tip characteristics, the volume, the definition, the width and the projections and the rotation. But sometimes what happened, then we have some advanced deformity in the tip, then we use scissor dena, other types of the tip grafts. So first we discuss regarding this central limb. Sometimes what happened, then your distal part of the septum, that is the weak, and you need a lot of uh, projection. When you need the lot of the projection, then columella strut, that is not enough. In that case, you use the septal extension graft. So septal extension graft is basically a structural graft, reinforcement of the distal part of the septum. No need in each and every case the septal extension graft, but you need the strong foundation of this tip, then you use the septal extension graft. Because Dr. Pawan have a long series of the rhinoplasty, so they experience that the columella strut later, the patient developed the dip, lost the support and the droopy tip. So the septal extension graft we use, this is small part of the septum, बड़ी cartilage होगी बड़ी, और हाँ ये रही ना. So this is a big piece of the cartilage, big piece of the cartilage. So according to you the need काटने के लिए दे. So the same thing, the indication, then the shaping and the placement and the fixation for any graft in the rhinoplasty for the learning. So we indication we discussed, then or distal part of the septum is weak, or we need more good strong projections, then we use. Then the shaping ideal is that 20 millimeter, that is the length, and around the 25, that is the height grossly, but you can modify the, but the 20 mm, that is the length, and 25, that is the height. So suppose this is your septal extension graft, then you can place it either in the end to end manner or in the end to side manner. इनको दोनों को यूं कर लो, सेल्फ रिटेनिंग लगा लो लेटरल क्रस्पिक, ये देख इधर लगाओ. So the end to end and end to side, if you use, look that end to end, then you fix in this manner, okay, just like a now the suture of this one is little bit difficult. So just to counteract this problem, there is another method, that is the end to side. That means few millimeter of this we scissor वो देना, tooth खोले, overlap like this, like this. So this is the overlapping manner. In overlapping manner, then how you fix? You pass a needle. You pass a needle from the one side to the another side. Needle dena yaar. But again, the important thing, uh, sometimes this part of the septum is thick, so it creates the block. So the good technique that you just thin it, the overlapping part. So to counteract that problem, and then you pass a suture. इधर से लगाना है मेरे को. From one side to the another side, just the horizontal mattress suture. So look that this is a manner. Then you fix this from this side, ऐसे पकड़ो, and again from the opposite side to this ipsilateral side, and so you fix again the 3 knot. ये needle निकाल लो भैया. And according to your need, you use 2 or 3 needles. You fix it. Never. I never use. But I revise lot of case of the silicone and matte pores. I always use either the septal cartilage or the conchal cartilage, or if you have the don't option, then I use the rib cartilage. So this is the use of the spreader graft. But look that with the spreader graft, sometimes uh, some unwanted effect. I fixed earlier in like this direction, but somehow with me or my assistant, if we have the problem, and if I'm not conscious, if this graft is rotate like this, then what happened? The nose is derotate. Okay, or if this graft is just like this, then you have some unwanted effect. The nose is over rotated. So this is the problem in this septal extension graft. It's a very good graft, but you use it very judiciously. Okay, then you when you analyze that, rather than the patient need only, because whenever you project something, then the no then the rotation is automatically comes. So this is the about the septal extension graft. Okay, and sometimes if you have a short nose, you want to make it the longer, then you use a like the this septal extension graft, and on both sides like you use 2 extended spreader graft, so you long your nose, short nose. Okay, so this is the one technique. We discuss the technique for the rest of the 5% of the septum. 95% we connect by the 5 tip techniques, and one another technique that we need for modification of the this part, that sometimes you see that this part of your columella is excessive like this one, and you have a excessive columella show. Then how you correct that? Then you use the tongue in groove technique. What is the tongue in groove technique? That means advancement of your this medial crust, advancement of this medial crust on the native septum. That means the septum, basically that is the groove, and the both of this just like a groove and the tongue. So that is the tongue in groove. So how you suture it? That just like we go behind and pass a needle and we suture it. That is the tongue in groove. But sometimes what happened, then your native septum is weak. Your native, yeah, picture is lost. एक बार देख लो. He changed the battery. So sometimes your distal caudal part is weak. Then how you fix it? So first you use the septal extension graft, and on the septal extension graft, give me the needle. You advancement of this medial crust like this, and like this. So the name, that is the modified tongue in groove, the modified tongue in groove, and we suture it. But the tongue in groove give the good projections, but always rotate the nose also. And yeah, yeah, and both this medial crust, like the my tongue, that and that is the central, and my lip, that's just like a groove. So that we call the tongue groove. Advancement of this medial crust on the native septum, that is the tongue, basic tongue in groove. But if your distal part of the caudal part septum is weak or absent, then first we reconstruct by the septal extension graft, then with the modified tongue in groove. But in tongue in groove or in the modified tongue in groove, then sometimes the patient develop a like the stiff this one, because we lost the membranous septum. So we little bit left for just movement of the tip. Uh, there is another term, that is the tongue in groove setback. So you never confuse about that. Tongue in groove, modified tongue in groove, we usually use for getting the projection. But the tongue in groove setback we use for the deprojection of the nose. So what we do in the in the tongue in groove setback, sometimes if your nose have a over, just like a projected nose, then how you correct that? Then you just separate this medial crust from this rest of this skin, and then make a incision, and then you overlap few millimeter, and then you suture, and then you advancement on this either native septum or the septal extension. So that is the tongue in groove setback, just for the deep projection of the nose. Both. Look that this is your, we incise just like this. So we reduce the length of the medial crust and we derotate the nose. In that case, we make an incision little bit higher when we open the nose. We earlier discussed these things. So basically, this is the two technique in mostly in the advanced tip, like the tongue in groove and the septal extension graft. And in the last, we have like this lateral nasal wall regarding the deformity, because it's also important, because sometimes you have the patient have a ella collapse, or like the blockage in the nose, caudal septum deviation, or the lateral wall nasal deformity. So mostly patient have uh, regarding the problem of this lateral crust, because the lateral crust have one deformity regarding the volume, have maybe this is a big volumic lateral crust, so we can reduce. But sometimes you know what happened, this lateral crust have some uh, problem regarding the sap. Ideally the sap of this lateral crust, that is the convex, but sometimes like in this patient also, this patient have basically the concave sap, so that we call the paradoxically lateral crust deformity. So how we correct this? When you correct the paradoxically lateral crust deformity, then give me the seizure. इसको नीचे वाले को पकड़ो. Because the paradoxically lateral crust deformity also create the problem of nasal blockage. So you just try to separate it. If you put the infiltration on one side, that is the better. Counter traction is important. Role of your assistant, that is also important. इसको hold करो. Sometimes if we have a minor like the paradoxical, then you can use a small piece of the cartilage, and then cartilage small piece you can put. But if you have a grossly paradoxically lateral crust deformity, then it's very difficult to correct, because if you put a big piece of the cartilage on as just like a overlay graft, then that have a pushing effect. So I cut it, and look that I cut it, I separate completely. And sometimes accidentally, if you have a buttonhole, then you suture by the 6-0 vicryl rapids. So then this is my lateral crust. So in the dome defining lines, you just like cut it and just it flip it, like I show you. I cut it, you just cut it, and the concave shape just go down like, and we suture it. suture करना है, इसको पकड़ना. So when you change the contour, then you just trim it little bit and then suture देना. Then suture, उसको hold करो. By the 5-0 PDS sutures, you can. So this is the lateral crura flip. We rotate it at almost 180 degree. So this is the lateral crura flip technique for correction of the paradoxical lateral crura deformity. Cut it. Yeah. Hmm. Uh, because maybe the lateral crest is already weak, or you excise it more and then create the problem, then just open it, and we use some graphs. So I show you after this graph. So basically this is the lateral crura technique, lateral flip technique for correction of the paradoxical lateral crura deformity. So after the volume deformity of the lateral crust, after the regarding the shape deformity, one deformity sometimes have the lateral crust. What that have a orientation deformity. Look that ideally the direction of this distal part of the lateral crust is look towards the lateral. This is my lateral canthus. So look that this is like this one. Sometimes what happened, the direction, because ideally this is the midline and this is my direction. So ideally it have the 45 degree from the midline. Rather than sometimes it's the 45 degree angle, it have the more cephalic position like this one. Then what happened? That is the cephalic malposition of this lateral crust. When you have a cephalic malposition of the lateral crust, then this part of the ala, the lost the support, and this part the central is prominent, that we call the parenthesis deformity. So the sometimes the patient develop the like the moment in this, and he have a deformity the central part of the. So how you correct it? We just separate entire lateral crust from this one, okay, and then we reposition it towards the lateral canthus, okay. Reposition of this lateral crust. How we reposition? Because for the reposition we need something for fixation of the lateral crust, okay. ये नहीं, ये देना. So now how you fix in the lateral? Because in the lateral position, then वो देना मेरे को. So look that this is the distal part of the lateral crust and this is my graft. So we use this graft in the two manner. First, either I keep it like this or either I keep like this. Suppose I keep like this, then what is the name of this graft? that is the lateral crura strut graft. Okay, give me the needle. Yeah. Okay. Yeah. I call you. Yeah, I call you. Yeah, so it's okay, sir. So you pass this needle from top to bottom like this. Okay. Now another method of fixation, like I remove this one and I put it like this. Then this is the Ella batten graft. So one is the lateral crura strut graft. If you put your proximal part of your this graft on the under surface of distal part of the lateral crust, then we call the lateral crura strut graft. But in the same, if you put this end on the distal part upper surface, that we call the Ella batten graft. Now again, I usually use the lateral crested graft if I use if someone give the option, because the when you use the इसको करना, when you use the lateral crested graft, then this graft have the pushing effect on this lateral crust, but Ella batten graft have the push effect, so they don't have a good option. So we fix like in this manner. You pass this needle from, इसको लगाओ, at least you need 2 or 3 sutures. So I make the note. So this is the lateral crura strut graft. Just for getting more strengthening of this lateral nasal wall. Okay. So like you asking if your patient have a Ella collapse, then you use this for getting more strengthening this lateral crura strut graft. And the another end of this graft, that where we place it, there's another end of the graft, then we make a we make a pocket just lateral to outer side of pyriform aperture, not medial side. This is the important thing. Outer side of the pyriform aperture you make this one, and this graft, where is that graft, this graft you put in this, and we suture already fix it here. So that's the new position of the lateral crust. This is the cephalic position of the basically lateral crust. Okay, so this we correct by this way the orientation deformity of the lateral crust. So these are the different deformities of this lateral crust that we can correct regarding the size, regarding the orientation, regarding the the shape. So we can correct by these graph. So these old techniques like septal extension, Stangin groove, lateral crest graph, they usually need in the basically the secondary case and some advanced case. I advise to the my beginning friends, then initially you try to do the 95% simple cases, so you get up the more and more confidence. Okay, so this is the sixth basically golden step. If we discuss like the first, that's the infiltration, and the second that is the opening of the nose, exposure, and the third is the septal modification, and the fourth that is the bony vault modification, fifth this is the mid vault modification, this is the sixth, and seventh we already I show you in the, so this is the seven golden step of the rhinoplasty. So if you do in the systematic manner, then you have the less and less chance of the deformity and residual deformity and the problem. And if you have the any questions regarding, and then you can ask and you can discuss. And I think what is the time? Management of the retracted columella, that your patient have a retracted columella, then you use this septal extension graft, because use by this septal extension graft you can forward this columella. And sometimes if you have a ella retracted, really ella retracted, because the nose have the two types of the length. One is the central length and one is the lateral length. There is nine different type of the combination of the length. Sometimes we have a over hanging columella, sometimes retracted, or sometimes retracted ella, or sometimes we have a hooded ella. So first we decide that what we have the deformity. Suppose you have a deficient the ella margin, then you use the composite graft. So it depend on the deformity, because the composite graft they have a not have the more than 1 centimeter limit. So it's depend on the deformity which type you use the graft. Other than you have any questions, then Ella rim graft sometimes like he asked, then like the Ella collapse, or sometimes some rhinoplasty surgeon they frequently use just for getting the more good contour of this Ella. Otherwise, routinely I am also not using, but it depend. There is no clear cut indication. But if sometimes if you have like you need the collapse of this correction of the collapse of this LRE, then you need. No, if you use the columella stud, there is no. If you use the tongue groove, there is no need to the columella stud, because we don't have the space between the medial crust. Because columella stud we usually put between the medial crust, between the medial crust. Uh, I think we just discussed the entire thing, and one the Ella base excision I should be little bit discuss more, because that is a one more point. So the Ella base excision is basically, frankly speaking, in my practice also, in your practice also, you try to avoid it in in the first stage until unless the patient have a sound indications. In the African patient and that have a wide Ella base, so they frequently use the Ella base because sometimes that is a type of the illusion also, because sometimes when the nose is like the droopy, then you appear Ella flaring, but after the projections, after the projection, then you think then, oh, there is no need of the Ella base excision now. So but the patient is now the under anesthesia, how can you ask then I do the Ella base excision or not? So earlier you ask your patient, then I decide if I need, then I do. Otherwise, it's the simple procedure we can do in the local. And definitely, and sometimes what happened after the 6 or 10 months, the patient settle down. Oh, it's good. But if you do the LMS excision and the patient asks, oh no, no, I no need what, then it's very difficult. Okay, but if you need then LMS excision, then give me the कोई भी marker दे दे हाँ ये दे दे. So first you decide that what you need. Either so first decide about the ella base width or the nostril width. First you judge that, because either your inter-LR width is more or your nostril sill width is more. Okay, because both things are the different. If your inter-LR width is more, then you excise this ella base. But if you have this more nostril width and you excise this one, then nothing to happen. So in that case, you excise the sill excision. And if you have the both, then you do the both ella base and the sill excision. Now, how, just like we discussed, then when we need the osteotomy, when we need the ella base excision, how we decide? So that they decide by this ella rim. So if the ella rim is outside of this ella base, like this, and you have this ella base width is more than this intercanthal distance, then you do the ella base excision. So when you do the ella base excision, then you mark, give me the marking. नहीं चल रहा. This is the nasofacial groove ना. This is the nasofacial groove. So your incision that not exactly on the groove, not exactly on the groove, just this little bit outside, and another incision that is the semi-lunar manner. There is a lot of other technique for the ella base excision. So we just excise this in the skin and the subcutaneous tissues, and we suture by the 60 or 50, probably not, because in the fourth or fifth day we open it. But sometimes if you want to excise this ella base and the seal also, then you extend this incision like in the trapezoid manner, and we excise this seal part also. Okay, so we excise the ella base with the seal excision. So we reduce this ella base distance and the seal area also. So I think this is all about the basic steps, and now after that you just, I think the just take your lunch, and then just you open it, and then if you have like feel it the things about the different anatomical part of the nose. And any questions regarding? Basically, in the tighter manner, in the tighter manner. First, you exercise few millimeter, and then you check, and you put that skin, and just you measure that, and the same by caliper you mark it on that side. That is a good thing. That is a good thing. But I personally then I ask to the patient, then if I need then do, otherwise, and in mostly I my patient then after the 6 months, after the good projection, then patient asks that, oh, it's okay, that's fine now, because patient appreciate the things, he doesn't know, then after the projections automatically this correct. So these are the things in rhinoplasty. When you do more and more cases, then you develop your own technique. So thank you for participating in this cadaver dissection demonstrations. And if you have the any query or any questions, then you can put my Facebook and the YouTube page, and definitely I'll reply of your query. And thank you once again. Uncle. Yeah, we have in the graph in the cases. Uh, you want to about the conchal cartilage exposure? We we can see in the rib, or we can see in the patient, no problem. We have the case, so uh, we do in that case the rib and the conchal also. Lot of cases, because now lot of times they are angry na another. So it's okay. है ना? इसको यहाँ से बंद कर दिया, इसका ऑडियो बंद कर दो।